Good morning, everyone. It's my pleasure to welcome you all this morning to this interesting and scientifically charged session. I would like to thank the organizers, Dr. Meenu Walia and Dr. Vikas Talreja, for giving me this opportunity to convene the radiology session of recent clinical updates from SABCS. I'm sure this will provide a forum for the exchange of knowledge and ideas about new standards of care, advances, as well as emerging strategies in the treatment of breast cancer. I hope we review and critically assess the practice changing research and go back with lessons learned that will steer a future practice in the best interest of a patient. We have seen remarkable trends towards de escalation in the treatment of breast cancer over the last few years. The buzzword these days is less is more. For today's session, I have selected majority of the posters around this topic, which would be presented by our own speakers. And one of the important key lessons that I've learned while going through hundreds of these abstracts before selecting a few is artificial intelligence is going to become an integral part of our profession. It will help us to remain ahead, and if we embrace it, we would be able to provide best of treatments to our patient. So let's understand what is AI. And to present this, we have Dr. Kritika Rangarajan, who is a postgraduate from AIMS and has done postdoctorate from IIT in artificial intelligence. So over to you, Dr. Kritika. Welcome, Kritika.
Thank you, ma'am, for that introduction. So I will just share my screen and then begin the presentation. Sorry. So is my screen visible? If I may start.
Yes, ma'am.
All right, thank you. So, I'm today talking to you all about everything you wanted to know about AI, but you were afraid to ask. I am an assistant professor in the All India Institute of Medical Sciences. And at the very outset, I'd like to thank the organizers for giving me this opportunity. So the presentation I'm presenting was originally presented by Professor Regina Barzile and was entitled What AI Can and Can't Do for Healthcare. And I hope to be able to capture the essence of her presentation as I go forward. So talking about AI versus usual clinical practice, usually clinical decisions are based on research which was conducted on a very small fraction of patient data. For instance, it was actually seen in a study that only about 3% of patients actually participate in clinical studies, which are the basis for us to decide many treatment options that we use in the current day, which is where AI comes in, because it actually gives you the ability to analyze much larger fractions of patient data. So we're hoping that the kind of conclusions we can derive when we do use AI in our clinical practice can be based on a much larger percentage of patients. So one of the most common forms of AI that we use, AI is a very broad term, but what we use commonly when we talk about most of the tasks that we use in clinical practice is called supervised machine learning. So what is supervised machine learning? Supervised means that you basically teach the system what you want to what you wanted to predict. For instance, if we were to take some examples from our real world, when we log into Netflix for the first time, when you create a user account and log into Netflix, Netflix asks you to choose 3 movies that you like the best. This is an example of how you're guiding the Netflix algorithm by telling it what your choices are. So the ground truth here is your choice of movies. Similarly, when you go to Google Photos, it would first ask you to pick out and name the people. It would pick out some faces and say, what do you call this person? So this is you guiding Google Photos and telling Google Photos that this is the person. So the ground truth you are providing is the name of the person that you would like Google Photos to identify for you. Similarly, if you were to take this to mammograms, the supervision comes from either drawing a box around the cancer, if it's a detection task, if what you want to do is detect the cancer, or if you simply want to classify an image as being cancerous or non-cancerous, you would guide the machine learning tool by really telling it whether the image has cancer or does not have cancer. So this kind of task where you are teaching the algorithm during the training phase what you want it to predict is called a supervised machine learning task. So going further in the same example that we were talking about in terms of predicting preferences from data, this is one of the examples that Professor Regile had given in her talk. When you actually choose the movies that you like, let's say that a movie you don't like is annotated by a -1, and a movie that you do like is given a value of +1. Your task is basically now to go ahead and, given a new movie, predict whether or not you are likely to like this movie. So the task of the machine learning is to learn some features in this particular list that you have provided it, which makes this movie likable to you, as an example. So what are these features it could learn, and how are they provided? So these features could be explicitly provided. For example, if the algorithm was to ask you a question about, say, the genre of the movie, then you could come to a conclusion that the first few movies were action and thrillers, and say a comedy was the second one, and try to piece together this information that you've given it, and probably think of something like, if it's an action plus a comedy, that's something that you seem to like. So that's an example where a feature is explicitly provided. However, if you have a very large number of training examples, like we often do in today's day, if you have a deep learning algorithm, which is what we commonly use in today's day, a lot of these features can be automatically picked by the network. When you put together these features and you construct a vector, this mathematically is called a feature vector. So this is how a feature vector is formed from the information that you provide the network. The next task is simply to provide a decision boundary. So what is the decision boundary? If you were to represent each movie in space mathematically, geometrically, then let's say that each movie actually occupies one particular point in this particular graph. Your task as a machine learning expert would be to find this boundary which separates the movies which are liked versus the movies which are not liked, so that when you are able to allocate one particular point in space to this new movie that has come in, you would know whether it falls on this side of the line, which is the liked side of the line, or the unliked side of the line. So finding this particular line in space is a mathematical representation of the model that you're trying to train. This, of course, is an oversimplification of the task. Often real life decisions are not based on one or two factors. So it's not a two-dimensional figure that you're going to get over here. It's a multi-dimensional figure. And even your decision boundary is likely to be a much more complex function, which may look something like this. And if over here you wanted to separate the red dots from the blue dots, you might want to find an extremely complex function that does so in the best interest to get the maximum sort of benefit in terms of the separation. One very common question that is often asked while starting a machine learning task is, how much data do we need to train such a task? So there is no single answer to this question. It really depends on a lot of factors, one of which could be the complexity of the task that you're looking at, another of which is the complexity of the model you're trying to train. But in general, when you keep increasing the data, the accuracy of the system is likely to get better. This is not going to be a linear sort of relationship where, as you keep increasing the data, the amount of increase may not be proportionate to the increase in data. For instance, when you go from, say, 10 images to 100 images, there's a huge jump in accuracy. However, when you go from 500 to 1000 images, there's only a minimal change in the accuracy. And this change may not be really worth the effort that you put in to collect the data. This, of course, is just for representation purposes, and we're not really talking about 500 or 1000 training examples. This is a graph which is plotted out of one particular example for a task. So if you were to actually design a supervised machine learning task, what would be the steps that are important to go forward? Firstly, you convince yourself that there is actually a pattern in data, because if you give data without a specific pattern in it, the task is really not going to be able to find a mathematical function to represent that. The second task to do would be to decide what features to use. Now, this data abstraction feature is more important when it comes to some of the older techniques. When you come to deep learning, like we had discussed in the previous few slides, you're not actually picking out features. That's something that the network learns from the data that you give. But in some of the older machine learning tasks, you do explicitly tell the system what features to pick out. So how many features should you pick out? Should you pick out a lot of features, or should you pick out just a few features? As a general thumb rule, it's a good idea to pick out as many features as possible, even though some may be irrelevant. This is because the modern day tools that we use for machine learning are extremely powerful and are capable of handling even the irrelevant features. However, if you miss out on picking out some relevant features, you may not be able to compensate at a later point. To give you an example for better clarity, let's say you're actually performing a task where you want to pick out certain features on a mammogram, which may help you decide whether or not it is a malignancy. You might be thinking about picking out, say, the margins, the shape, the density, etc. But if you were to skip one of these and then provide it to the machine learning task, which means that if the machine learning task simply doesn't know whether there was architectural distortion or not, as an example, then it will not be able to utilize this for formation of the model, which makes you make a much less accurate model than you would have ended up with otherwise. The next task is to collect annotated data. Now, this is perhaps the most boring and the cumbersome step of the process. It is extremely cumbersome to sit down and carefully annotate data, but it's also one of the most important steps because this essentially determines how robust your network is going to be. And the last is to evaluate your model. The importance of this step in medicine cannot be overemphasized, given that in medicine, the scope for error, of course, is much lesser than there is in any other field, perhaps. So evaluating your model, looking for possible biases that may have come out of choosing your training data, choosing an appropriate test set which is large enough, which has enough variety, is all a very important step before you can actually go ahead and put it into your clinical practice. So we kept speaking about deep neural networks. So what are deep neural networks? We commonly use these deep neural networks, which derive their inspiration from the biological neuron. So just the way you have sensory organs which pick up your sensations and then pass them on to synapses, which will then pass them to the next layer of neurons. Loosely, this is where deep neural networks get their inspiration from. There would be an input layer. So these are the inputs that you're giving, the images or the other variables that you want the network to take as input. Then there are many, many layers of mathematical functions. At the moment, it would be sufficient to just call it some mathematical functions that are going on over here. And then finally, an output layer, which is your final prediction layer. These are essentially called hidden layers. And some layers will get activated. It's called activations, just the way some neurons and some synapses get activated and then pass on the information to the next layer. This hidden layer is very large in case of a deep neural network, which is why they call it deep. That's the meaning of the term deep. And this depth gives it enough complexity to be able to handle very large amounts and very large volumes of data. Why has deep learning really come to the fore in today's day? Deep learning and machine learning as a concept have been there around for decades together. However, today we stand at a position where we have lots and lots of digital data, which is very easy to transfer. In addition, we also have a lot of computational resources. For example, graphic processing units, which are the kind of systems we use to analyze these images particularly. This is particularly important when you're using images for your task. And all this gives us capability to handle very large models, which become easy to train. And they literally fit like flexible Lego pieces. And you can take and borrow from these networks which have been trained on natural images and then simply use them for your medical images in today's day. Computer vision is actually fairly similar to what humans do. Of course, it's not half as complex as what humans do, but in general, just the way human vision develops, where you sort of learn to identify simple things first. You learn simple parts and you put together these parts to understand what objects are made up of. Similarly, in computer vision, also, it's been seen that the earlier layers actually learn very simple features like edges in this case. This is a face detection algorithm. The next few layers would learn slightly more complex things. For example, if you were to visualize what the mid layers of this neural network is learning, you would start seeing some noses and some eyes, and all these are pieced together when it comes to the last few layers to complex facial structures, which is what the network is trained to learn. And this is the hierarchy with which the algorithm actually learns to identify things. So the tasks that machine learning can do is essentially divided into tasks which can be automated, the tasks where humans are actually experts and can be automated to do. Then there are the tasks which humans really cannot do. So these are the superhuman capabilities that we are trying to exploit of machine learning. And the last, which is an emerging field, which is not something which has been extremely well explored, is gaining fresh insights and trying to understand certain disease processes. And coming to the first task, which is tasks which humans can do, machine learning can actually be extremely effective at doing such tasks. And let's look at an example of why that happens. The author, Professor Regila, actually spoke about a study which was studying atypia progression. And before the AI era, these are two articles from very reputed journals, one from the New England Journal of Medicine, the other from JAMA. And the number of cases they saw were about 336 in the first case and 674 in the second case. So like you can see, even though atypia is as common as it is, the number of cases they were able to churn out and study was a fairly small number. With AI, however, AI gives us the ability to really analyze a much larger subset of cases. It's easy to construct a data set with about 6,000 cases, because now you don't have to manually go over each report to find the atypia. And that gives you the ability to look through your electronic medical records and find these in a much more robust way. However, finding this is not going to be trivial, because not everybody would write atypia in the same way. This was one particular example she gave, where she's talking about how somebody would call it a severe atypical ductal hyperplasia, going on to someone calling it a borderline DCIS. So finding these terms is non-trivial. It would need several queries for you to give it in. And a particular kind of machine learning that can do this, deep learning in fact, is called natural language processing, which allows you to understand language rather than simply just finding phrases which it can match. And this has really expanded our ability to go over medical records in order to come to sound conclusions. One particular area of caution before we move on to the next use case is that tasks cannot typically be completely automated with the use of AI. It's a good idea to not do so, because the weaknesses of AI is very different from the weaknesses of human beings. And sometimes things which are very obvious to humans can be missed by AI. Similarly, human interpretation actually brings in a certain value which cannot be replaced by AI, which brings us to the very common epithet that radiologists who use AI are likely to replace radiologists who do not use AI. And machine learning tasks actually bring in a very narrow intelligence which is specific to one particular task. And looking at a replacement model is likely to not take your project very further, because it's unlikely that something like that will be possible in the near future with the current abilities and capabilities of artificial intelligence. Coming to tasks which actually extend human capability, um, deep learning is capable of finding certain features which may not really be truly visible to the human eye. For instance, if you were to look at progression of certain lesions to become cancer, this is one area where humans actually don't do very well. This is an example from the author's own study, where she talks about a particular lesion in the breast, where the task was to predict a 3-year progression of lesions into cancer. And they were able to show that in their data set, AI actually did much better than humans when an outcome of that kind was being fed. So AI actually became a much better predictor of future, which is something that humans cannot really do quite as well. And in addition to showing it on their own test set, they showed it on data sets which were derived from across the globe. And as you can see, they reported extremely high accuracies and comparable accuracies to the original test set across the globe, showing that this was actually fairly generalizable to the general population. Another area where AI has been shown to do excellently well is predicting the risk of development of cancer. So traditionally, when we as human beings do this, we use factors like age, family history, prior breast procedure, and at the most, if we're using images, say in mammography, we can use something like a breast density. But actually, dense breasts actually constitute up to 42% of mammograms that you read. So this is not a very useful way of stratifying the risk. This particular study actually looked into that and developed AI models which are capable of predicting the future risk of developing cancer. And the authors of the study were actually able to use it in the real world during COVID times, where by predicting the risk of development of cancer, they were able to call back patients who were specifically at high risk to continue with their annual screening, even though screening as such was not being offered during the COVID situation. So this is one example of where AI can actually bring in true value in the real world and change the clinical practice, the way we look at it. What do you really train AI to do could be something which is explicitly measurable. For instance, all of these examples where predicting cancer was the outcome, or it could be something that we are not capable of looking at as human beings. For instance, if we were to actually just try to predict the histology from a mammogram image, that could simply be an outcome that you ask AI to predict. So your model is going to be trained the way you kind of give it the outcomes to train it with. Two important questions that the world of artificial intelligence is trying to answer is: how do we ensure that these models generalize, and how do we interpret those models? So coming to generalization of models, what generalization typically means is you may have shown the accuracy on a particular test set, but what are the chances that this accuracy will actually carry forward when you go into a fresh situation, a new test set, which may come from a different distribution, different patient distribution, a different region of the world, a different race of human beings. So often, or even different equipment which are used to acquire these images. So this problem of generalization is something that the AI community as such is struggling with, and several checklists have come out in the recent past. CLAIM is something that as medicos we may all be aware of, and similarly the MICAI generalizability checklist, reproducibility checklist is another one such checklist to ensure that your model is built in such a way that it is likely to generalize. Another important hurdle is interpretability of these models. Often you may have heard of people referring to these AI networks as being a black box. And the reason we refer to them as black boxes is because it's very hard to understand what the AI algorithm is trying to decipher. While in case of humans, you can simply go and ask them why they made a certain decision. AI possibly cannot tell you why it made a decision that it did. So interpreting these models to understand what they're looking at when they're making a decision is extremely important. Some examples of where this can go wrong and why this is important. One of the examples that Professor Regli mentioned is this particular example where the network was trained to predict or to guide the treatment procedure based on information it gathered from electronic medical records. However, when you look at the electronic medical records, not all patients are fortunate enough to get the same kind of treatment. Because of some inequalities, certain races in the United States, where this article actually comes from, did not receive treatment simply because of financial difficulties. And the algorithm ended up being trained to not provide or not predict a certain kind of treatment for these races simply because what it read from the electronic medical records was something completely different. It read that a certain race was actually getting suboptimal treatment, and it ended up guiding medical treatment in the same way as it had been trained to do. Another example would be that clinicians typically have different thresholds for calling it a cancer. For instance, if you were to try to predict, again, I'm taking the mammogram example again, cancer from mammography, and you were to use the BIRAT score, there would be a high variability in how different clinicians actually give a BIRAT score. And therefore, if you use a non-standard, non-gold standard, non-histological gold standard for training these algorithms, there would be a lot of noise in the way these algorithms are actually trained. And if we don't take care of such biases, AI could actually end up worsening healthcare disparities across the world. This is another example of interpretability and the reason why generalizability and interpretability is quite that important. So this was an algorithm which was trained to predict or detect human beings. Now, if the algorithm was fairly confident in calling this particular thing a monkey or a non-human being when the guitar was not there. But the minute you put in a guitar on top of this image, the algorithm very confidently predicts this to be a human being. The reason for that being that every time in the training data, the algorithm saw a guitar, there was always a human being holding it. So this kind of represents the kind of biases that can be introduced into the system. And one example, if I was to give from our own practice, at one point in time when we were training algorithms to detect pneumonia, the training examples had a lot of ICDs in patients who did have pneumonias. So the algorithm ended up taking ICDs as a surrogate marker for presence of pneumonia. And this is something that we ended up realizing when we gave a different test set where the patients did not have ICDs. So this kind of dangerously, explicitly exposes the kind of biases that you could introduce very inadvertently. And these biases can be very difficult to pick up because of the number of factors that are there in medical science in making a particular decision. So it's very important to ensure that the algorithm actually generalizes to different kinds of patient populations before you can actually put it into clinical practice. One little caveat when it comes to interpretability of cancer is that sometimes cancer may not really be. Although you can sort of derive heat maps, you can say where your network is focusing while making a particular decision. When it comes to tasks which have a suprahuman capability, it may not really be possible to to really tell why the network actually made this decision. And that makes interpretability very complex because for things that we don't know, it's very difficult to verify whether the network is actually doing the right thing or not, and verify whether what it's doing is for the right reasons or not. And with that, I'd like to thank you all for your attention. In the interest of time, I'd just like to skip this slide and hand it over back to Dr. Jyoti.
Thank you, Dr. Kritika. That was a wonderful talk. So now understanding the science behind the AI, I presume my initial thoughts when I had heard about AI was that, it is creating a lot of hope, but like cat, it will not stand test of time. But now knowing the science behind it, I'm sure AI is going to stay with us, and it's as early as we embrace it, the better it would be for us and as well as for the patient care.
Yes, absolutely. I think AI is on a completely different technology standpoint in comparison to a CAD. So,
thank you, Dr. Kritika. So the next talk would be by Dr. Varsha Hardas. She is the in charge breast imaging Ruby Hall Clinic and Grand Medical Foundation, Pune. And she'll be talking about single institution retrospective analysis of lymph node change on breast MRI in patients with high risk early stage breast cancer receiving neoadjuvant chemotherapy with and without immunotherapy on the I-SPY2 trials. So over to you, Dr. Varsha.
Single institution retrospective analysis of lymph node changes on breast MRI in patients who have high risk early stage breast cancer and are receiving neoadjuvant chemotherapy with or without immunotherapy on the I-SPY2 trial. Now, the I-SPY2 trial has shown that the addition of immunotherapy to standard neoadjuvant chemotherapy resulted in improved rates of estimated pathological response for hormone receptor as well positive as well as triple negative breast cancer. Now, to further try another drug and augment this effect, a combination of intratumoral SD101, which is a synthetic drug, along with pembro and chemotherapy was added, and also showed that there were increased estimated PCR rates when as compared to chemotherapy alone. But it was not. It was also associated with high rates of immune-related toxicity when immunotherapy was added to this. Now, this was a subset of a small retrospective analysis to see and assess the changes in the regional lymph nodes seen on MRI in these patients who were receiving neoadjuvant chemotherapy as well as immunotherapy, and explore and see if these changes in the regional lymph nodes ultimately correlated with the primary endpoint of complete pathological response and the residual cancer burden. So to check that, these patients were divided into 3 arms. One was the control arm, which received the normal chemotherapy regimen. The second arm, in addition, got 4 doses of pembro, and the third arm, along with the pembro, also additionally received intratumoral SD101 drug for 6 doses. So this is a chart which shows that these patients were randomized for this investigational drug regimen. They were all followed by the adriamycin AC cycle that after they finished this regimen, and followed by surgery. Now, during this course, they also had multiple breast MRIs, which were performed in all the patients, and they were at baseline. The first MRI was done. The second MRI was done at 3 weeks. The third MRI was done at 12 weeks. And the last MRI was done at 20 weeks after finishing and completion of the treatment just before the surgery. Now, all these MRIs were read by a single breast radiologist who was blinded to the treatment arm. And they reviewed the MRIs and mentioned the longest diameter and cortical thickness of the largest ipsilateral axillary lymph node, also mentioned the number and the location of abnormal lymph nodes, and also the development of new abnormal lymph nodes over time. There were a total of 43 patients with median age of 45. Most of them were premenopausal. 58% were hormone positive and 42% were triple negative breast cancers. Now, when the lymph node sizes were recorded across all timelines of MRI at baseline, 3 weeks, 12 weeks, and preoperative, this was the graph that was seen in the control group as well as the patients who received the immunotherapy. And what we see here is the change in the lymph node or the development of new lymph node over the time was significantly more common in patients who received immunotherapy as compared to the control group. But when these two groups of patients who did have increase in size and patients who did not have any increase in size of lymph nodes on MRI, when they were compared and correlated with the endpoint of PCR, that is complete pathological response, or residual cancer burden, or even the hormone receptor status, that correlation did not have any statistical significant data. It was not statistically significant. This is an MRI of one of the patients who is on SD101 arm, and the MRI done at baseline, 3 weeks, and preoperative. Here we distinctly see that in the 3-week MRI, the size of the ipsilateral lymph nodes has increased. There is also appearance of newer lymph nodes over here. Now, when we look at the data of this SD101 arm 16 patient, we see that there are 10 patients who showed lymph node changes across all time points. And there were 7 patients who were receiving immunotherapy showed immune toxicity. But when you look at this chart, what you realize is that patient who showed some lymph node changes need not or did not necessarily show immune toxicity, whereas patient who did show immune toxicity did not necessarily show any lymphadenopathy changes or emerging of newer lymph nodes. So to conclude, what we can say that the addition of immunotherapy to the standard neoadjuvant chemotherapy in these patients did show who were associated with increase in the ipsilateral axillary lymph node on serial breast MRI. These were the patients who showed these changes, but they were not associated with worse pathological response at surgery. And therefore, these change in lymph node size or appearance of newer lymph node should not be assumed due to disease progression. This is a small retrospective study. The lymph node change of patients on immunotherapy was also not associated with either improved pathological outcome or hormone receptor status or immune-related toxicity. Now, whether these lymph node changes could reflect immunotherapy benefit needs to be investigated in a larger study and longer follow-up. And if we are able to do that, if we are able to show that these lymph node changes on the MRI were showing immunotherapy benefit by different means or by testing some biomarkers, then we will be heading and we'll be able to predict and we will be able to give more personalized treatment to these patients, where we can safely allow all these patients with good response as seen on MRI because of lymph nodes or other parameters to receive less treatment and have less toxicity, while we can also predict if patients who are non-responders can go ahead and have a complete neoadjuvant chemotherapy. So this is what we conclude from this study. Thank you very much.
Thank you, Dr. Varsha. This was really informative. So generally our tendency is when we see a lymph node increase to presume it's a progression. So now we need to, so we have seen concepts of pseudo progression in other areas of cancer imaging. So we need to keep in mind that this could be a possibility while doing a response evaluation on serial MRs. But obviously we need more data
more study, more data, and also there are multiple parameters, like it can also be, this was a lymph node study, but it can be the basic tumor response and the tumor volume, assessment of diffusion and everything put together probably will yield some good results in a larger study setup.
Thank you, Dr. Varsha. So
you.
the next talk would be by Dr. Ekta Dhameja. She's the Associate Professor, Radiodiagnosis, AIMS, Delhi. And she'll be talking about contrast-enhanced mammography in breast cancer surveillance. Over to you, Dr. Ekta.
Yes. Ma'am, am I audible?
Yes, you are.
Okay, thank you. Good afternoon, everybody. So this is one of the abstracts from SABC, and it is related to contrast-enhanced mammography. Now we know this is the upcoming modality which has shown promising results. So the same has been kept as a background for breast cancer surveillance by authors from Royal Melbourne Hospital in Australia. So what they have focused is what they have, how they planned was that it was a retrospective analysis, and they included patients who had a personal history of breast cancer, saying that these are the group of the patients who are at increased risk for local recurrence or developing a new primary breast cancer. So actually they are also advised for regular surveillance imaging, and that is why they included all these patients. According to NCCN guidelines, annual mammography is what is advised for them, but not the other modalities in their setup. So whenever there is dense breast, or whenever the patient has a personal history or is a high-risk patient, would warrant a supplement screening with either ultrasound or MRI. So this scenario is kind of slightly different from our scenario, because they have studied that supplement ultrasound, though it increases cancer detection rate, but since it is associated with low specificity and it would warrant large volumes of surveillance, they would want they have tried to compare if the recall rate or the ultrasound rate can be reduced while using contrast enhanced mammography for such patients. So contrast enhanced mammography, we know that has high sensitivity and good specificity for picking up cancers, which are seen as enhancing lesions in their institute. And by practice, they had started doing and offering contrast enhanced mammography as the imaging modality starting from 2018. So that is how they have included the patients, and that was the data set for them. In one setting only, they have obtained 2-dimensional full-fledged digital mammography, 3-dimensional, that means tomosynthesis and contrast enhanced, with the aim to review the outcomes of all those who are undergoing first surveillance contrast enhanced mammography. The data has been recruited from the departmental database starting from October 2018 to June 2020, and all the radiological and pathological details were extracted from their databases only. So what they say is that they have included first surveillance contrast enhanced mammogram with 2-dimensional, of course, and all the mammograms were read, and the data which was collected was BI-RADS, mammographic density, background enhancement, and they correlated it with the gold standard of histopathology. And they tried to estimate if contrast enhanced mammography could detect additional lesions and what were those lesions, plus if introduction of CEM could reduce their ultrasound rates. So they could include 1,195 patients, out of which 961 had bilateral CEM, 234 had unilateral, that means the patient had already undergone mastectomy for index surgery of the other side. What they realized was that whenever they have used CEM, they had markedly reduced ultrasound screening. Out of these 1,195 patients, 1,000 patients had prior invasive cancer and 193 has only DCIS. So the results which they have postulated and they have presented had kind of mixed findings. What they say that out of all these patients, 33 were the ones who were only reported on CEM. And they had done 70 biopsies. Out of this, 37 were true positive and 42 were false positive. And out of those 33 patients which were detected only on CEM, 22 could have a correlate on 2D or 3D, that is tomosynthesis mammogram, and 15 were only seen on CEM. Out of those 15, few were DCIS, few were invasive, and predominantly the ladies have denser breasts, that is BI-RADS C category. Of all these findings, 15 had true positive, and 18 had false positives. The elaborative details about these have not been included in the abstract per se, but since their aim was to evaluate how much ultrasound detection or ultrasound utility had reduced, so they compared the same data set with the 1 year back data, the ladies who had undergone same mammogram surveillance a year back before they introduced CM. So what they found was that out of 2,781 mammograms, only 891 required ultrasound 1 year prior. And after the introduction, out of almost 3,000, only 400 ladies they subjected to ultrasound. So they found that they had 55% reduction in bilateral ultrasound. So it is just to summarize that 1195 patients underwent either bilateral or unilateral CEM, had both IDC and DCIS, so not the other variants were included. 33 lesions were detected on CEM, and true positive were 15 and false positive were 18 on biopsy, when biopsy was kept as gold standard. So they concluded that routine CEM should be the main imaging strategy for surveillance of the patients who have high risk of recurrence and have previous history of breast cancer, because it was able to highlight additional findings which could change the management outcome. And this was associated with major reduction in bilateral ultrasound use. Further assessment obviously is warranted because it was predominantly the kind of study which could evaluate only the ultrasound, and there was no two arms to say whether it is actually there or not, and long-term impact was not studied. Although these results in the study is quite promising, while going through this, there were some concerns which came into my mind. Considering our scenarios, which was that they have not elaborated on what false positive biopsies were done. And also, if we go back to the results, it was not clear what 70 biopsies are we discussing about and what are these 33 biopsies. And maybe we would be more keen for the full text to understand what were the false positive rates. That was one thing. Similarly, for false negative, and if we could get a positive predictive or negative predictive value, which I'm sure we'll get soon, and whether we'll be able to replicate the same study in our scenario, because at this point of time, we are struggling for digital mammography per se. And if we are trying to compare whether the ultrasound should be reduced if we introduce contrast enhanced mammography, though it is an ideal situation, but it is still a far-fetched goal for our scenario. Thank you.
Thank you, Dr. Ekta, and also for your own interpretation. But I feel it might have a promise in those centers which have very huge patient workload. Like for example, AIMS, for ultrasounds, I see they have a huge waiting list. Even for our center where which are ultrasound, which is operator dependent, which is dependent on the doctors and not on the technicians, the waiting list can increase and the workload can be very high. So it might sort of offer promise for those tertiary centers where the workload is high.
I totally agree with you, ma'am. That is why I said that they have not given positive predictive and negative predictive value, because that will guide us to whom we should subject.
Yeah. Yes. So this is one area where we can do our own data and can do research work and see whether it has a promise for us or not.
Yes.
So thank you, Dr. Ekta. And now we have Dr. Janaki Dharmarajan. She's the Associate Professor, Breast Imaging Consultant at Amrita Institute of Medical Sciences and Research Center, Kochi. And she's here to talk about prospective ultrasonographic surveillance study for incidence and recovery period of COVID-19 vaccination-related axillary lymphadenopathy. I thought this would be an interesting work to listen to, because now again the booster doses are coming up, so we would again have those problems of axillary lymphadenopathy, and we can see what other people are, what is their approach for these kind of axillary lymph nodes. So over to you, Dr. Janki.
Okay. Yeah, it's seen. Am I audible?
Yes, Dr. Janki, you are audible.
Yeah. So thanks for the organizing team for giving me an opportunity to present this topic. So I'll be talking on prospective ultrasound surveillance study for incidence and recovery period of COVID-19 vaccination related.
Sorry to interrupt, Dr. Janki. Can you make it full screen into the presentation mode?
It's full screen. So
if you slide present, if you go into the present. Yes, you can go ahead.
Ma'am,
So I'll be talking on the prospective ultrasound surveillance study for incidence and recovery period of COVID-19 vaccination-related axillary lymphadenopathy. The study has been performed by Kida et al. At St. Luke's International Hospital in Tokyo. Next slide. Next slide. Yeah, so the background of the study is basically, it's a COVID-19 vaccination-related lymphadenopathy is a frequent imaging finding that is indistinguishable from the malignant nodal involvement. It leads to diagnostic difficulties and prompts unnecessary intervention in individuals who are for routine cancer screening or those with cancer history. An expert panel from USA had recommended a delay of 6 weeks from the final vaccination to schedule routine screening to allow for reactive lymphadenopathy to resolve. But there were no prospective trials for COVID-19 vaccination-related lymphadenopathy using imaging examinations. It is crucial to confirm clinical facts and recovery process of lymphadenopathy based on imaging examination. Next slide. So the purpose was to determine the incidence and imaging characteristics of COVID-19 vaccination-related axillary lymphadenopathy by ultrasound examination, and to assess the recovery period required for improvement of the lymphadenopathy based on prospective ultrasound surveillance. So the women aged above 20 who were working in St. Luke's Hospital were enrolled, and these women had received at least, all of them had received second shot of Pfizer COVID-19 vaccination within the preceding 8 weeks. And the enrollment was carried out between May 1st to 27th of 2021. The exclusion criteria included history of any cancer or surgical history, any history of surgery in the upper limb or axilla, and the patient participants who are having atopic dermatitis or autoimmune diseases, because all these conditions can independently lead to lymphadenopathy. Ultrasound assessment was performed for bilateral axillary lymph nodes at enrollment. If lymphadenopathy was detected, an ultrasound was performed every 3 weeks until lymph nodes showed resolution. The lymph nodes in ultrasound having a short axis dimension of more than 5 millimeters were considered to be significant. And the questionnaire was also used at the time of enrollment to inquire about the other side effects attributed to vaccination. So on day 0, the initial study was done, and the participants who were found to have lymphadenopathy were followed up every 3 weeks with ultrasound. Next slide. So the incidence rate and imaging characteristics of lymphadenopathy detected by ultrasound were evaluated. The recovery period required for the improvement of lymphadenopathy were assessed using Kaplan-Meier method, and the association of lymphadenopathy with other side effects was assessed using the chi-square test as well as Fisher's exact test as appropriate. A total of 135 women were enrolled in this study, and the median age of the participants was about 37 years, and none of them had history of COVID infection. And the period from second vaccination to enrollment was about less than 4 weeks in 7% of the cases, and maximum about 93% had just after 8 weeks, just before 8 weeks. Next. So the results showed that on ipsilateral side, almost 50% of the patients had a lymph node that showed a short axis dimension of more than 5 millimeters. The long axis dimension was not very significant. And on the contralateral side, only 10% of the enrolled people had a lymph node of more than 5 millimeters size. So half of the patients demonstrated ipsilateral axillary lymphadenopathy at the time of enrollment. That was approximately 6 weeks. And the number of lymph nodes were also determined. So of the 50% of the patients who had enlarged lymphadenopathy, almost 19% had only one lymph node involvement. 18% of the patients had two lymph node involvement. 10% had three lymph node involvement, and 4 and 5 were seen in approximately 3 and 1% of the enrolled participants. The ultrasound features that mimicked suspicious lymph nodes included cortical widening that occurred in 43% of the patients. The lymph nodes were hyperemic in 11%, and absence of hilum was seen in 11% of the patients. So the ultrasound features that mimic malignant lymph node was noted in approximately 43% of the patients. These were seen only in the ipsilateral axillary lymph nodes. And the recovery period from lymphadenopathy was determined. Week 6, that is at presentation, the lymph nodes were seen in almost 48% of the patients. In week 2, this had regressed to 38%. By week 10, only 17% of the patients had lymphadenopathy, whereas it still persisted in 6% of the patients by week 12. So half of the patients showed ipsilateral axillary lymphadenopathy detected by ultrasound at 6 weeks post-COVID vaccination, and it persisted up to 10 weeks, and most of them they resolved at 12 weeks. So this was the first study. This is the first prospective study to determine the incidence and recovery of the vaccination-related lymphadenopathy based on ultrasound features that is readily available. So the main highlights were half of the participants showed COVID vaccination-related axillary lymphadenopathy based on ultrasound, and the imaging characteristics were indistinguishable from malignant nodal involvement that were observed in more than 40% of the patients in vaccine-related lymphadenopathy in this study. Next, please. So the recovery period from lymphadenopathy was commonly observed even at 8 weeks and mostly resolved after 12 weeks from the second vaccination in this study. So in the previous review, COVID vaccination-related lymphadenopathy had persisted for more than 6 weeks in 29% of the patients, whereas here it showed that up to 12 weeks it is persistent in up to 6% of the patients. So what are the clinical implications of these of the findings? That is, a non-urgent imaging examination such as breast cancer screening would be recommended to be postponed to at least 10 to 12 weeks following the latest vaccination. And the patients with with breast cancer should be vaccinated on the contralateral arm to the site of primary cancer to avoid diagnostic conundrum. And the patient's vaccination information, that is the date of vaccination as well as the injection site, should be available for the clinicians and radiologists for accurate diagnosis and management. So to conclude, due to high incidence and imaging characteristics of COVID-19 vaccination-related lymphadenopathy, non-urgent breast cancer screening would be recommended to be scheduled at least 10 to 12 weeks following the latest vaccination, and the patient's vaccination information should be taken into consideration on cancer screening and diagnosis. So this is the reference.
Thank you, Dr. Janki. It was very relevant in today's scenario of what to do if we find axillary lymphadenopathy in patients of breast cancer surveillance. So thank you. Next, we go to Dr. Vinita Kapoor. She's the Senior Consultant Radiologist at Fortis Lafem Hospital, New Delhi, and also at Colonel Pant Imaging Center. And she'll be talking about intelligent shear wave elastography to reduce unnecessary biopsies in breast cancer diagnosis and international multicenter analysis. Over to you, Dr. Vinita.
I'm sharing my screen. Is it visible? shear wave elastography to reduce unnecessary biopsies in breast cancer diagnosis, an international multi-center analysis conducted by Andre Forbes et al. So, what exactly is this study about? We know that breast ultrasound identifies additional cancers which are not detected on mammogram, but it has a false positive rate which increases financial and emotional burden. Elastic assessment or elastography was mentioned as an associated feature in the latest edition of the ACR BI-RADS Atlas, which is 2013. And it is based on tissue compression producing strain or displacement, which is smaller in suspicious versus non-suspicious masses. So we know elastography as having two varieties, the strain and the shear wave elastography. Some images on the right and below, which are taken from our own work, which shows the areas which are soft or non-suspicious as white on strain elastography. And now with the use of quantitative elastography or shear wave elastography, the hard images as red. The velocity is taken in meters per second and converted to kilopascals. Coming to intelligent shear wave elastography, can it actually reduce the unnecessary biopsies without missing any cancer compared to B mode ultrasound and traditional shear wave elastography? So there are two machine learning algorithms, and Kritika had a wonderful presentation which sort of enlightened us all about what this was all about. So there's one with logistic regression with elastic net penalty, and the second is logistic regression with neural network, which she explained in detail. This particular study had a cohort of 857 women who underwent B mode breast ultrasound, shear wave elastography, and histopathology at 12 study sites in 7 countries. It was trained and tested on 11 sites with 10-fold cross-validation validated on the remaining largest sites. The outcomes then were plotted. And this is what they showed. So if you can see, there's a comparison in the diagnostic performance of B mode breast ultrasound, traditional shear wave, which we know of, and intelligent shear wave elastography. And the highest or the greatest accuracy is produced by the group which has the neural network. So there's certain important things that you have to look at. The AUROC, as Kritika had explained, or the area under the region of curve, the most important area under the region of curve of interest. If you have values between 0.8 and 0.9, such values are considered excellent by statistical data. Values greater than 0.9 are outstanding, which is seen in both intelligent shear wave elastography with net penalty and with neural network. We also look at both negative and positive predictive values. The negative predictive values with both intelligent shear wave elastography forms showed a value as high as 100%, which is phenomenal. The positive predictive value of 61.5% was seen with neural network, which is far greater than what we see with shear wave elastography and far more than what we see with B mode ultrasound. In our experience with shear wave elastography at our center from 2014 on Siemens S2000 and its correlation, we found that shear wave elastography has very encouraging results as such in distinguishing between BI-RADS 3 and 4A lesions, which are not easy to differentiate on B mode. And this particular thing shows that even the area which is green shows a value of 4.38. The area which is the hardest would be far above 4.5, which is considered as the cutoff value. Machine learning algorithms have the potential of being then the future of diagnosing breast cancers without biopsies. Very, very important. This will reduce both the economic and the emotional burden on the patient. The little figure I have below has shown the difference between deep learning, machine learning, and artificial intelligence, which Kritika explained as well. So according to the multi-center study conducted by Andre, a machine learning algorithm, which is intelligent shear wave elastography, reduced unnecessary breast biopsies by a whopping 50% without missing any cancer compared to breast ultrasound, which is a phenomenal amount. Thank you for the patient hearing. We would be coming out with our own atlas on breast elastography within a month or so. Thank you so much.
Thank you, Dr. Vinita. It's firstly, congratulations for the launch of the book that you are planning. I'm sure it will enlighten all of us. But it's very encouraging to see that such things are existing and people are researching, and if we can validate those algorithms in our own population, we can really reduce not only the anxiety the patient has when he undergoes a biopsy, but also in our country it is going to significantly reduce the financial burdens on the patient.
And maybe we could also have a multi-center trial for something like
that.
So would be an interesting way forward, I think.
Yeah. Thank you. So now we are going to Dr. Rupa Ranganathan. She's the lead consultant in she is the lead consultant, Department of Diagnostic and Intervention Radiology, Kavoy Medical Center and Hospital. And she'll be talking about small open surgery versus minimally invasive vacuum-assisted excision for small screen-detected breast cancer, a phase 3 randomized trial. It would be really interesting to see the results from this trial. Over to you, Dr. Rupa.
Thank you, Dr. Jyoti, for the kind introduction. At the outset, I would like to thank the organizers for having me on board this year again to discuss the best posters from SABCS. So the topic that I'm going to discuss is from a multicentric trial funded by NHS UK, the SMALL, which is the open surgery versus minimally invasive vacuum-assisted excision for small screen-detected breast cancer, a phase 3 randomized trial. Looking at the background of this structure of the study, as we all know, screening mammography when applied to the general population will detect early breast cancer, which has a significant impact on reducing the mortality and the life expectancy of the women. It also detects, when we do screening, it detects small tumors which have a favorable biological feature which may not progress. However, all of them are traditionally managed with open surgery, which is basically a breast conservation surgery with sentinel lymph node biopsy. And vacuum-assisted excision has been used for almost 2 decades now for treating benign lesions and lesions with uncertain malignant potential. This study, SMALL, uses vacuum-assisted excision of small screen-detected breast cancers which have a biologically favorable features, and all of these cancers are detected in the UK NHS screening program. So the aim of the study is basically, as I said, this is a phase 3 randomized control study which aims in comparing the standard surgery with vacuum-assisted excision and seeks to determine, is this approach feasible and acceptable to the patients? And can it be done with an acceptable re-excision rate? And what would be the long-term local recurrence and its implications? And can sentinel lymph node biopsy be omitted in these group of patients? So the structure of the study is, as I said, it is a screen-detected malignancy, and the size criteria is less than 1.5 centimeter. And all of them, when they are screen-detected through a mammogram, undergoes a routine diagnostic core biopsy. And the key eligibility criteria is all women who are above or equal to 47 years on screen-detected mammography, and the size of the tumor should be less than 1.5 centimeter in its maximum dimension. There should not be any associated microcalcification outside the mass. Basically, it means that it should be just that 1.5 centimeters and shouldn't be any associated DCIS outside the mass. And it should be a unifocal disease, a grade 1 tumor, and they should be ER/PR strongly positive and HER2 negative. And they should have either a normal axillary ultrasound, or if there were some lymph nodes which were raised a suspicion on imaging, they should have a benign FNAC or a biopsy report. And they should not have any prior diagnosis of ipsilateral DCIS or invasive cancer. When the patient have fit into all these eligibility criteria, an informed consent was obtained and randomization happens. So on the randomization, one arm is the surgery arm, wherein they undergo wide local excision with sentinel lymph node biopsy, followed by a radiotherapy based on the local practice. If the local practice omits radiation, and they omit radiation, and they also undergo hormonal therapy. In the vacuum-assisted excision arm, and they are all with post-procedure. Following a vacuum-assisted excision, the excision completion is assessed by a post-procedure mammogram. And if they find that the excision is incomplete, they undergo surgery right away, which is the standard wide local excision with sentinel lymph node biopsy. And if the mammogram confirms complete excision, they undergo radiotherapy and endocrine therapy based on the local practice. So what is the rationale behind the study design is, first and foremost, it is a randomized trial, and the end point is the non-inferiority of the vacuum-assisted excision, which means that the re-excision rate are on par with surgery, which is 15 to 20% in UK. And the data, the recurrences of following surgery and radiotherapy are less than 1% at the end of 5 years when they follow the standard surgery with the sentinel lymph node biopsy. So the acceptable recurrence rate should be less than 3% following an vacuum-assisted excision, and anything which is more than 3% is considered unacceptable. So the primary endpoints are two. One is the re-excision rates, because even for a sentinel, even for a wide local excision followed by sentinel lymph node, the re-excision rates in UK, the data says around 10 to 20%, and hence the same re-excision rate is fixed for vacuum-assisted excision also. And the local recurrence based on the data of the standard procedure is less than 1% at the end of 5 years, and hence the vacuum-assisted excision should have a local recurrence rate of 3% at the end of 5 years. They also have certain secondary outcome which measures the complication rate in both arms, the overall survival, the quality of life, and the cost effectiveness analysis. So the total of 800 patients were expected to be included in the study with 2:1. It means more women were selected for vacuum-assisted excision. So the surgery arm will have 257 patients, and the vacuum-assisted excision arm will have 533 patients. And the total number required to assess the re-excision rate for the VAE has a little more than 5%, considering the dropouts. They have calculated an estimate of 762 women. And as I said, the probability of success in both arms is 80%, considering the 20% re-excision rates. And the minimum acceptable difference between both the arms is only 10%. And the total number required for calculating the recurrence is 511, with an expected survival after 5 years is 99%, which means there is only less than 1% recurrence rate at the end of 5 years. And the undesirable in the vacuum-assisted excision arm is we have a survival rate of 97%, which is basically anything more than 3% recurrence rate is considered an undesirable survival. So the level 1 is basically understanding the recruitment process, and the level 2 is development and implementation of the recruitment intervention strategies. And based on this poster, they have published the data on recruitment and progress till 18th November 2021, and 18 centers from NHS are open for recruitment, and 10 centers have recruited 60 patients, and 55% of these recruited eligible entry have consented to randomization. So they also have mentioned, because the COVID has impacted this study, and hence not many numbers have been started as expected. And when I go through the literature, I see similar trials with VAB in the breast cancer. One is from Netherlands, which is a mini VAB, which also has got a very similar structural design, which is 1.5 centimeter non-lobular cancers. And they basically have, they should be hormone positive tumors. And this one is very interesting that it is not a randomized, and all the patients in this mini VAB undergoes both vacuum-assisted excisions and 3 weeks later surgery, which is basically a lumpectomy with sentinel node lymph node biopsy. And the surgery is the vacuum-assisted excision is considered successful when the surgery, the pathology from the surgical specimen says there is no residual tumor. And this is basically a pilot study. And as we all know, the cryoablation has also been used in breast cancer, and the phase 3 interim results of the ICE3 trial is published last year. And this is a prospective multicentric trial, again, with women, but they are only when they are more than 60 years of age, and they have included low to intermediate grade tumor. And again, it is a small tumor, 1.5 centimeter, again, a hormone positive, HER2 negative tumor. And the 3-year interim results published last year said the ipsilateral recurrence rate was 2.06% after the cryoablation, and more than 95% have exhibited satisfaction on the cosmetic results. Thank you.
Thank you, Dr. Rupa. So it will be very exciting to see the results of this trial, and hopefully the results would be encouraging. With this, we go on to the next topic. Dr. Smriti Hari would be talking about the next poster. She's a professor, Department of Radiology, AIIMS, Delhi, and she'll be talking about multi-center prospective study to predict pathological complete response by vacuum-assisted breast biopsy based on MRI and ultrasound findings after neoadjuvant chemotherapy. Over to you, Dr. Smriti.
Now that we are talking about de-escalation of surgery in breast cancer patients, Rupa talked about one scenario where early breast cancer can be, subjected to VAB. I'm going to talk about the second scenario where the exceptional responders to NACT may be offered vacuum-assisted breast biopsy and be spared surgery. So for this, I'm presenting the poster by Hayashi and et al., a multi-center prospective study to predict pathologic complete response by vacuum-assisted breast biopsy based on MRI and ultrasound findings after neoadjuvant chemotherapy. So the background for this poster is that we all know there's a high pathologic complete response rate after neoadjuvant chemotherapy, but the radiological findings are not very.
Dr. Smriti, can you please make it, sorry to interrupt, can you please make it full slide?
It is full slide on my, you can't see it full slide? Surgical excision remains a standard treatment for patients with breast cancer. So the objective of this poster was to assess the accuracy of CCR, that is clinical complete response by VAB, in addition to MRI and ultrasound finding for every subtype of primary breast cancer patients who achieve clinical complete response, that is CCR, after chemotherapy. So this was a multi-center prospective cohort study, which was undertaken in 5 Japanese institutes. And all patients with clinical T1 to 3 stage, any node who achieved CCR in MR and second look ultrasound findings were enrolled, and appropriate chemotherapy was given to these patients. And afterwards, at least 5 ultrasound guided 10 gauge WAB samples were collected before surgery. And definition of clinical complete response.
Ma'am, sorry for intervening. Your slides are not moving.
We are still stuck at third slide.
Why is my
Ma'am, if you can permit, we can share your
please do
slide.
that. Please do that, I think, in the interest of time. So, right. Yeah, so next slide, please. So PCR was defined as no evidence of residual invasive or in situ carcinoma. Next, please. And the primary outcome measure was the NPV and false negative rate for radiological findings and for WAB in combination with these radiological findings in each subtype of breast cancer. Next. So there were 96 eligible patients, out of which 8 had to be excluded and 88 were included, out of which 29 patients were triple negative, 39 patients were HER2 positive, and 20 patients were triple positive. Next. 95% of the patients who were assessed as the YCT0 means the Y stands for assessment after chemotherapy. So after chemotherapy, 95% patients were assessed as T0 stage, while 5% still had tumor. And number of WAB samples obtained were 5 to 16 with a median of 6. So the tumor stage after chemotherapy, 47 were deemed to have 0 stage, that is complete response, and which is 53%. Next. Now, if we see the residual tumor in WAB, almost 80% did not have residual tumor on the WAB sample. So that means out of the 70 patients with no residual tumor in WAB, only 47 were actually free of tumor on final pathology. So that is already suggesting that we have a high false negative rate of WAB sampling. Next. So coming to the tables which are assessing accuracy of radiological assessment for complete clinical response after chemotherapy, when you just look at the radiological assessment without WAB, the negative predictive value overall is quite high, low rather, 75%. And the highest is in the HER2 positive patients, which is 84.6%. Next. Accuracy of radiological plus WAB assessment actually went down because WAB is having a lot of sampling error in this study. The NPV is down to 67% overall, and the false negative rate is unacceptably high at 56%. Next. When you consider only the absence of invasive cancer in the pathological specimen, again, the FNR is still high. It is 66% with a negative predictive value of 71%. Next. They have made a review of literature, and you can see that mostly in the literature, the FNRs are quite high. 56%, 49%, 50%. Only in the initial studies, we have a low FNR of 5%, which is not replicated in any of the studies, and 30%. Next. So the conclusion is that WAB, in addition to radiological findings, was not accurate enough to predict PCR in any subtype of primary breast cancer, and they could not support elimination of surgery by WAB for patients who achieve clinical complete response after neoadjuvant chemotherapy. And possibly the reasons for this high FNR could be that there was no patient selection done. Patients with associated DCIS were also taken. Patients of all subtypes were taken, whereas we know that the assessment of radiological clinical response is better in HER2 positive and TNBC. The samples taken were only, the median was 6. So possibly that is low number of samples, and there was no intention to make sure that the clip is removed in all patients, which would be a further indication to appropriate sampling. So in view of these lacunae, maybe further studies should be designed looking into these points. Thank you.
Thank you, Dr. Smriti. So with this, we come to our next talk, which would be presented by Dr. Jwala Shrikala. She is the consultant radiology at KIMS Hospital, Secunderabad, and she'll be talking about intelligent VAB to identify a breast cancer patient with pathological complete response after neoadjuvant systemic treatment for omission of breast and axillary surgery. I would just request all the speakers to stick to the time. We are really running behind our schedule.
Yeah, thanks, Jyoti. And I think it's a wonderful platform, and thanks very much. Are my slides in slides mode? Yeah. So basically, as a culmination of whether VAB can be an answer to complete excision following neoadjuvant chemotherapy, this basically the study has included a lot of patient pathology imaging variables along with the VAB results to formulate an AI program which could reliably predict omission of surgery both for the breast as well as for the node, and conclude that VAB excision would be the final answer to the disease. So basically, this is an AI study which included a lot of pathology and radiological inputs. So this was performed by Andre et al. And we've seen so many papers presented by this group. So neoadjuvant systemic therapy elicits a pathologic complete response in 40 to 70% of women with breast cancer. So in such cases, breast surgery may be considered an overkill and overtreatment to these patients who have responded extremely well to systemic therapy. Imaging and VAB has accurately detected and excluded residual disease without surgery. We evaluated multivariate algorithms using patient, tumor, and VAB variables to identify patients with breast complete pathologic response. So what the aim of the study was to train, test, and validate a machine learning algorithm, which was named Intelligent VAB, using patient, imaging, tumor, and VAB variables to detect residual cancer after neoadjuvant systemic therapy and prior to breast surgery. So they were just testing to see if it could conclusively tell us if we could omit surgery. So they evaluated not just the primary tumor, but also the lymph nodes after completion of neoadjuvant chemotherapy. Now, what were the methods that were adapted? So the main AI algorithm that was used is called the XGBoost tree algorithm. XGBoost is an implementation of gradient boosted decision trees designed for speed and performance. XGBoost is an algorithm that has recently been dominating applied machine learning and Kaggle competitions for structured or tabular data. So this is a lot of technical jargon, but simply put, this is one of the AI machine learning methodologies that is adapted, especially when you have a structured and a tubular form of data available. So training and testing was done on 318 women with T1 to T3. Unlike early breast cancer, they included women with T1 to T3, N0 or N node positive, HER2 positive, triple negative, or luminal B. So they kind of included almost every kind of breast cancer, every kind of clinical and pathological breast cancer in their study with 10-fold cross validation. External validation was done on an independent trial, and the outcome was to know the false negative rate of all these variables put together with the help of the AI versus surgery. So this was the conclusion. So if you carefully look at this chart, when they used imaging after neoadjuvant chemotherapy, the false negative value was 24%, specificity was 65, the negative predictive value was only 68.4, and positive predictive value was 73.1. When it was WAB alone, the false negative rates were 28%, specificity was 100, negative predictive value again was only 74.1%, and positive predictive value was 100%. When they combined imaging as well as WAB, then the false negative rates fell to 12, specificity was kind of 65, the negative predictive value was slightly better at 81.3, and positive predictive value was only 76%. WAB plus patient selection criteria, when they used, the false negative rates fell to 4%. The specificity was only 30%, negative predictive value was 85%, and positive predictive value was 63.2%. But when they put all the variables, now we'll have another slide to see what were all these variables, and they used the intelligent WAB, you would see that the false negative rate was 0% and negative predictive value was 100%. So if the intelligent WAB told us that there is no disease, there was no residual disease, then it meant there was no residual disease, and WAB excision was completion of treatment. And this particular patient need not go for an open surgery. So the variables that were included in this, and to know the influence of these variables, this is the slide that shows us that. So the variables were WAB, post-WAB presence of cancer cells, and down below you can see the Sharp value. Sharp value is nothing but the impact that each one of these variables would have on the outcome of the AI result. So WAB, presence of cancer cells in WAB had a very high influence. Accompanying in situ tumor had a very high influence. Then there was largest diameter of the residual tumor after neoadjuvant chemotherapy, largest diameter after NST, WAB needle size that was used for excision, the value of Ki67 of the tumor, the patient age, the WAB specimen numbers, the WAB deemed unrepresentative by pathologists, WAB mammography guided, progesterone receptor status, estrogen receptor status, multicentricity after NST, multifocality before NST, the primary grade of the tumor pathologically before NST, and histological subtypes. All these were the variables, including the needle size of 8G and 9G. And you can see that this chart shows us the influence of each one of these variables on the outcome of the AI result. And so we saw that when we used all these variables and we put them into this AI program, which used the XGBoost algorithm, then the negative predictive value was 100%. So it was concluded that a multivariate algorithm can accurately select breast cancer patients without residual cancer after neoadjuvant chemotherapy because its false negative rate was 0. So what would be the future direction for research using this AI? It would, the end desired result would be a complete omission of breast and axillary surgery for these exceptional responders to NST, may be evaluated in the Yeah, so that completes my presentation. Thank you, Jyoti, for giving me this opportunity once again this year. And I think it's an excellent, excellent learning platform for all of us. Thank you.
Thank you, Jwala. This was really interesting and very unbelievable results, I would say.
Absolutely, absolutely.
We really need to validate the data before even we can think of, having any such thing in our standard of care.
True. And then this also tells us that if we radiologists don't upkeep ourselves with AI and the evolving AI, then I think very soon all of us become obsolete. So thank you very much.
Okay, thank you, Jwala. With this, we come to Dr. Mukta Mahajan. She's the consultant radiologist, breast imaging and intervention, Side Care Cancer Hospital, Bangalore. And she'll be talking about prediction of response to neoadjuvant systemic therapy in triple negative breast cancer using baseline tumor MRI characteristics and imaging pattern of response. Over to you, Dr. Mukta.
Cancer Center in Chennai now. I'm a consultant radiologist there. I'm fellowship trained breast imaging radiologist. I also take care of the breast cancer and gastrointestinal cancer management teams and interventional radiology. I'm really thrilled to present this study from a very active group in academics and research. The study is titled Prediction of Response to Neoadjuvant Systemic Therapy in Triple Negative Breast Cancer using baseline tumor MRI characteristics and imaging pattern of response. So let's quickly look at the authors of this study. There are about 29 authors from MD Anderson Cancer Center, Houston, Texas. Most of them hold prominent professors and associate professorships within the group. A lot of them boast over 8,000 citations and more than 50 publications in high-index journals. Of mention, Dr. Alastair Thompson. He's the professor-in-chief section of breast surgery in Baylor College of Medicine. And Dr. Stacy Mulder, of course, she is the professor and co-leader of breast cancer moonshot at MD Anderson Cancer Center. This is a $2.5 million philanthropically supported research initiative. Her affiliation is also with Eli Lilly pharmaceutical company. So as a background, we all know that triple negative breast cancer has poor prognosis. In America alone, between 2012 and 2016, over 12% cancers diagnosed were triple negative. In particular, the triple negative breast cancers who have significant residual disease at the time of surgery have poor prognosis at the end of completion of neoadjuvant systemic therapy. So this study is an effort to identify patients who are unlikely to achieve pathological complete response. Hence, the authors investigated if pre-treatment breast MRI with morphological characteristics and follow-up MRs that show image response patterns during the SNST can predict a pathological complete response in TNBC patients. This is a part of a larger Artemis clinical trial, which stands for a robust triple negative breast cancer evaluation framework to improve survival. It's a prospective IRB approved clinical trial. It estimated enrollment of almost 1,000 participants. It started in November 2015, primary completion date of 2021 November, and the study completion date is going to be 2023 November. The arms and intervention included tumor biopsy, the baseline evaluation, IHC, as well as molecular analysis, ultrasound, baseline lymph node evaluation, and the primary outcome measure was the response rate with a time frame of up to 5 years. So this particular study is a subset of 199 patients with biopsy-proven stage 1, 2, and 3 triple negative breast cancer that received neoadjuvant systemic therapy, and they were classified as PCR, that is pathological complete response, or non-PCR based on histopathology at surgery. The patients underwent breast MRI at baseline after 2 cycles of adriamycin-based chemotherapy. The second follow-up MR was done at 4 cycles of the chemotherapy. So the MRI studies were reviewed by 2 fellowship-trained radiologists who were blinded to the pathology results. The MRI morphological baseline features were based on ACR MRI BI-RADS lexicon that all of us are aware of. The imaging response pattern at C2, that is after 2 cycles, and C4, that is after completion of 4 cycles, were classified as follows. So type 0 was complete response, type 1, as demonstrated in this diagram, was concentric shrinkage, type 2 was a crumble, type 3 involved diffuse enhancement, type 4 was stable appearance of the tumor at the end of 4 cycles, and type 5 was progression. So the MR findings were used as a guide to intervene and change the neoadjuvant systemic therapy, and then these results were summarized and compared to the PCR status on surgical pathology. Fisher's exact test was used, and p-value of less than 0.05 was considered statistically significant. So a little brief about Artemis clinical trial. It offers triple negative patients personalized therapy, and the way it does that is that at baseline, when the patient has a breast core biopsy, they also run molecular profiling of the tumor. MRI, baseline MR and 2 MRs are done subsequently, and the mid-therapy imaging response pattern deem the tumors either chemosensitive or chemo-insensitive. The chemosensitive tumors continue AC chemotherapy followed by taxane-based neoadjuvant systemic therapy, whereas the chemo-insensitive tumors, the patient is offered opportunity to participate in one of the following 4 randomized single-arm therapeutic clinical trials that are linked to Artemis. So these 4 trials are listed out here. They involve drugs that block androgen receptors, which is seen almost in 15 to 20% of all breast cancers. They're drugs that involve the vascular endothelial growth factor receptor inhibitor, the mTOR inhibitor, the EGFR monoclonal antibody, as well as PD-L1 inhibitor. The interesting part of this study is that it does not waste any time. By the time the molecular profiling results are ready, the patient has already finished the first leg of the therapy and the initial analysis to assess whether the patient has optimally responded or not. So the results of this subset of patients, they were about, the median age was 53 years, age ranged from 24 to 79 years. For 95 patients, that is almost 48% of the patients had pathological complete response, whereas a slightly larger component, 52%, had non-PCR. So at baseline MRI, it was found that an irregularly shaped mass and homogeneous or clumped non-mass enhancement were associated with pathological complete response, and this was significantly statistically significant, as against a rim enhancement lesion or a circumscribed lesion or clustered ring non-mass enhancement pattern. Multifocality, peritumoral edema, and intratumoral necrosis were independent of the pathological complete response. In the following neoadjuvant therapy assessments with MR, most common MR response pattern was type 1. That means a concentric shrinkage of the tumor, which was seen with frequency, equal frequency in PCR and non-PCR at C2 as well as C4. This is a very interesting finding. The following response patterns associations were also found. Type 0 was associated with PCR at both C2 and C4 time points, significant statistically, while 4 and 5, which means a stable and an enlarging mass, were associated with not PCR even at C2. The 4 patterns from the crumble, diffuse enhancement, stability, and progression were associated with non-PCR at C4. The conclusion that was drawn from the study is that baseline MRI tumor morphological characteristics and MR imaging response patterns during NST may be valuable markers for PCR prediction in TNBC. Qualitative breast MR assessments may act as an accessible tool to identify TNBC patients who are unlikely to achieve PCR and may benefit from targeted therapies. There was an interim analysis by the same group, which was done a while ago, that used ultrasound as an imaging tool, and showed an interesting finding that the non-responders, the chemotherapy-insensitive tumors, who continued to standard chemotherapy and a taxane as a second phase neoadjuvant therapy, none of them had pathological complete response. However, those in the insensitive cohort who enrolled to one of the 4 therapeutic trials linked to Artemis, almost 50% showed pathological complete response. So it will be interesting to wait for 2023 to see the large 1,000 patient data, what results and what long-term overall survival data it produces. Some interesting studies published recently by the same group. And as Dr. Jwala just presented, the responder trial, one of the trials in 2018 was also done for the exceptional responders, where the surgery can be eliminated, and even this group is prospectively enrolling patients for another trial. Thank you.
Thank you, Dr. Yeah, thank you, Dr. Mukta. This was really very interesting, and we are really looking forward to the future times where I feel our role as radiologist is really going to change as clinical radiologists, and will be equal partners in management decisions.
That sounds good.
Okay, so now we go on to our next speaker, Dr. Palak Poput. She's the Associate Professor and Consultant Department of Radiology, Tata Memorial Hospital. And she'll be talking about functional tumor volume at 3 and 6 week MRI as an indicator of patients with inferior outcome after neoadjuvant chemotherapy. Can we have Dr. Palak? Is she there?
Thank you so much,
Hi.
Dr. Jyoti. Yeah, at the outset, I'm very glad to be here on this platform once again. Could you see my screen?
Yes, we can. Can you make it full?
Yes, just. Okay, so I will be talking on the functional tumor volume at 3 and 6 week MRI as an indicator of patients with inferior outcome after neoadjuvant chemotherapy. So the study was presented as a part of the I-SPY trial, which is the investigation of several studies to predict your therapeutic response with imaging and molecular analysis. So this trial has been conducted in phase 1 and phase 2 stages. It is presented by the authors of Onishi et al. At the San Antonio Breast Cancer Symposium. So talking about this trial, the background which is known is that we know that there is a response to treatment on chemotherapy prior to surgery. The idea is to identify patients who are undergoing an MRI and predict a response. So this study aimed to develop criteria based on the MRI tumor response to identify patients early on in their treatment who are on a trajectory to an inferior response as reflected by residual cancer burden. So there is an escalation strategy which is going to be used, and it is being used in the I-SPY 2 trial. And this is for a treatment option to redirect the potentially more effective therapy for patients likely to have an inferior response. So there is a pre-treatment MRI, and then those which undergo a poor response do have a week 3, week 6 MR, a week 12 MR, and then a pre-surgical MRI. The database behind this is a randomized controlled trial where they are adding the routine paclitaxel regimens for 12 cycles followed by other regimens, which is the standard arm, and the control arm is going to have many more new added chemotherapy agents to look at personalized medicine response. So MRI analysis is a subset of this larger ongoing randomized controlled trial. The background for defining what is residual cancer burden is that this is a post-neoadjuvant chemotherapy, post-surgery histopathological evaluation of the tumor volume or the tumor burden, also known as the RCB. It is established as a surrogate for predicting the survival outcome. So to look at the disease-free interval or the relapse which is seen over time at the distant sites as we go ahead with time, it is most poor in cases with an RCB3, which identifies a higher residual cancer burden. This was presented in the JCO, and it defines RCB0 as complete pathological response, which reflects a very good survival or disease-free interval in terms of disease management over time. And RCB1, 2, and 3 would be reflecting the tumor volumes, which is representing the increase in the tumor burden. The 2 and 3 show an inferior outcome, as is seen over here, with much more poorer outcomes seen in RCB3. For the treatment escalation option, patients likely to result in this category will require an earlier detection while they are on their standard neoadjuvant chemotherapy protocol. The purpose was to investigate the ability of a combined 3 and 6 week FTV, that is tumor volume, based criteria to detect RCB2 or 3 patients as candidates for the treatment escalation option. The number of patients taken were 104. They underwent an optional 6-week MRI between Jan 18 and March 21. The FTV reduction at 3rd week and 6th week MRI was compared. The methodology is to determine the functional tumor volume. This is obtained by analyzing the quantitative measurement of tumor burden derived from dynamic contrast enhanced MRI. And it was measured during the chemotherapy at various time points. The first one was prior to embarking the therapy, which was a T0. There was the first MRI after onset of chemotherapy at 3 weeks, labeled as T1, at 12 weeks, labeled at T2, and pre-surgical MRI was performed, which was T3. Now over here, an interposed MRI was taken up at an optional phase at 6 weeks for patients with low response at 3 weeks, and this was termed as a T1A in the time point manifestation. So what they then did was there was a dichotomization of the data in which analysis was done at 3 week and at 6 week, and the reduction from T0. So T0 is the time point prior to embarking therapy. The volume estimated was your T0 volume. From that, they would calculate the difference in the percentage of response. So a 20% response. So each was further dichotomized into less than 20% response, which would be very poor responders, or more than 20% response. The dichotomization for a 6 week happened at 65% difference of response, less than 65 or more than 65. After this, the cancer burden after neoadjuvant chemotherapy was termed as either a responder under 0-1 category or a non-responder, which was phase RCB 2 and 3 category. The statistical analysis was calculated by Fisher's exact t-test and the positive predictive value and sensitivity. The association between the tumor volume reduction and the residual cancer burden outcome was seen in 104 patients. Out of these, 49 were included with RCB and an analyzable FTV. A subset analysis of these was such that 31 out of these 49 patients were hormone receptor positive and HER2 negative. 16 were HER2 and HR negative, and 2 were HR positive and HER2 positive as well. So looking at the analysis, this was a volume, which was a relative volume compared to the time from the treatment that started. So we have a 6-week, 12-week, 18-week treatment. The MRI was performed at T0, which was MRI 1. There was a T1 MRI at the 3rd week. T1A was an optional 6-week MRI, and T2 was a standard MRI performed at the 12th week. So what they analyzed was from the onset of 0, there were different curves and graphs that were obtained. RCB 0 are the ones marked in blue, and the ones marked in greens are 1. So these were essentially responders, and they showed a very good rapid drop in the tumor volume after the initiation of chemotherapy. However, looking at the browns and the pinks, which were the poor responders, they observed that there were a fair amount of patients which did not undergo response at the 3rd week and subsequently at the 6th week. So an analysis was performed individually at the 3rd week and the 6th week. And what was observed that at the 3rd week, out of the 49 patients, 26 patients had very poor response with less than 20% reduction marked by the brown lines. So what we do see here is there is a poor response in a little more than half the number of patients, and a little less than half the number of patients underwent a very good response of more than 20% reduction. This gave a positive predictive value of 73% and a sensitivity of 68%, which was good. Now looking at the 6-week data, at the 6-week data, what was observed that we have n equals to so what we do observe at the 6-week data is that compared to the earlier 3rd week data, at the 6th week, n equals to 30, patients had a poor response of less than 65% reduction, and more than 65% reduction was observed in 19 patients. Hence, the patients who underwent a poorer response, some of them did show a good response later and continue to have a poorer response eventually over time. This had a positive predictive value of 80% and the sensitivity of 86%. So at 6 weeks, we had a better predictive values with us. Looking at a comparison of the poor responders, which were less than 20% reduction in the first category at T3, that is at the 3rd week, were compared with a combined analysis at the 6th week. So the 3 and 6 week combination showed that of the poor responders, 22 patients continue to have a poor response even at the 6th week, whereas some patients had an improvement in the response beyond the 3rd week up to the 6th week. This combination had an improved specificity, sensitivity of 95% and positive predictive value of 82%. So various cutoffs were analyzed where the entire subset of patients who underwent a poor response on T1 were analyzed at T1A, and they saw the response at less than 45% reduction, less than 50, less than 55, 60, 65, 70. So looking at various percentages of response among the poor responders, the best sensitivity and a combination of a good positive predictive value was obtained at a T1 of less than 20% reduction and T1A of 65% cutoff. So this is a fairly good analysis, and the conclusion was that statistical significant association was shown between the RCB outcome and FTV reduction at 3 and 6 weeks. A combined two-step criteria using FTV reduction at 3 and 6 weeks showed a high positive predictive value and sensitivity in early detection of non-responders. An optional use of 6-week MRI in this study may have introduced bias. Currently, they are requiring 6-week MRI for all patients with a limited early response, and the combined criteria will be further tested and refined in a prospective cohort in I-SPY 2. They do advocate that early prediction of non-responders will help physicians to identify patients who are not benefiting from their current therapy and redirect them to a different therapy or an added therapy that might work better for them. These are their acknowledgements. There is a good meta-analysis to look at, does an MRI perform well? Yes, an MRI performs very well in evaluating the pathological response to neoadjuvant chemotherapy in breast cancer. This is the data of almost close to 1,000 patients. The take-home message that I would say is that yes, MRI does predict pathological expected response. It is a road to personalized medicine. Not all patients planned for surgery undergo an MRI in our country. So we do need to look at a judicious choice of which patients are going to undergo and benefit from this category of evaluation in the management pathway. It would be good to triage the clinical non-responders and they undergo an MRI rather than every patient undergoing an MRI who is posted for NACT. And of these patients who do not respond after the after the 3-week period can be subjected to an MRI and then further interpolated data to T1A, T2, and T3 as proposed by the trial. Extrapolating response to findings on CECT would be of an extreme high worth because CECT is yet today in our times done for all patients, whereas an MRI is available only for a very small cohort of patients. Thank you so much.
Thank you, Palak. That was a really good, conclusion of the poster or the research work that was presented. And you have very nicely summed up how we can use it in our own scenario, which is financially, obviously, most of our patients would not be able to, have MRs at so many levels. So thank you. And with this, I would go on to the next speaker. Please, a request, kindly stick to your times.
Many thanks.
Thank you, Palak. Dr. Richa Bansal, she is the Principal Consultant Radiologist at Max Super Speciality Hospital, New Delhi, and she'll be talking about radiomics model based on MRI compilation and early predictor of pathologic complete response to neoadjuvant systemic therapy in triple-negative breast cancer. Dr. Richa, over to you.
Hello, everyone.
Hi, Richa.
I'm just sharing my screen in a while. Is my screen visible?
It's visible, Richa.
Okay, thank you. First of all, I would like to thank Jyoti for providing this excellent learning platform for all of us. So the abstract I'll be presenting is by Nabil Eshrafil et al., who studied radiomics model based on magnetic resonance imaging compilation or the MAGIC sequence as early predictor of pathological complete response to neoadjuvant systemic therapy in triple-negative breast cancer.
Can you please make it full screen?
I'll just do it. Wait a second. Is it visible now? Full screen?
Not.
I'm full screen. I've put it on full screen only.
You have to go into the presentation mode first.
Okay, just a while.
Otherwise, it's okay. Your slides are well visible, so we can go ahead.
Okay.
Yeah, perfect.
So the background of the study, triple-negative breast cancer is comprised of biologically aggressive tumors with diverse clinical behavior and response to chemotherapy. Prediction of disease response to neoadjuvant systemic therapy is critical to development of personalized medicine in TNBC. So in this study, they basically studied a novel MRI sequence, which is a magnetic resonance imaging compilation of the MAGIC sequence, which is capable of simultaneous quantitation of several tissue properties, including T1, T2 relaxation times, and proton density, which may be reflective of tumor heterogeneity. And radiomic signatures from T1, T2, and PD quantitative maps may play a useful role for treatment response evaluation in TNBC patients. So objective of this study was to evaluate the ability of a radiomic model extracted from a novel MAGIC MRI sequence acquired during NAST to predict pathological complete response in TNBC patients. So the patient selection included 184 women, 122 in training dataset and 62 in testing dataset who were diagnosed with stage 1 to 3 TNBC and enrolled in the IRB approved prospective clinical trial. All patients received 4 cycles of anthracycline-based chemotherapy, followed by 12 weeks of taxane-based therapy, followed by surgery. PCR was defined as absence of invasive carcinoma in the breast and nodes at surgical pathology. So they studied several features. The imaging features were studied. All patients were scanned with MAGIC sequence on a 3T MRI scanner at first of all at baseline and then after 4 cycles of chemotherapy. T1, T2, and PD maps were generated from the source images using a software, which is the synthetic MRI. Textual analysis was done later on. Tumor regions of interest were segmented by a breast radiologist at T1, T2, and PD maps using in-house developed software. And 310 textual features were extracted from each map. So a total of 930 features were studied for each patient. So this is the image showing the T1, T2, and PD quantitative maps which were generated by the MAGIC MRI sequence. So once the source images were obtained, this was followed by extraction of T1, T2, and PD maps from the MAGIC sequence and segmentation of ROI was done on each map. This was followed by selection of the volume of interest from each map and extraction of radiomic features. And then feature selection analysis was done to build the best model for PCR versus non-PCR prediction. Radiomic features were compared between PCR and non-PCR using Wilcoxon rank sum test. The area under the receiver operating characteristic curve was used for univariate analysis to determine textural features predictive of PCR. Logistic regression was used for multivariate analysis for feature selection and building the radiomics predictive model. And the model performance was assessed by leave one out cross-validation method. So in the results, they found that on univariate analysis, 35 PD, 42 T1, and 98 T2 radiomic features at C4 time point were able to predict PCR status with area under the curve more than 70% in testing and training cohorts. The top performing radiomic features were entropy, variance, homogeneity, and energy. On multivariate analysis, they found that multivariate radiomic models from C4 PD and C4 T1 maps showed best performance during both cross-validation and independent testing. The radiomic signature of C4 T1 map that included 27 features had best performance with area under the curve of 0.77 and 0.70 in training and testing cohorts respectively. While on C4 PD maps, there were 6 features were able to predict the status with area under the curve 0.73 and 0.72 in training and testing cohorts. So this was a multivariate radiomic model which was created for C4 T1 and C4 PD maps. So basically they concluded that this sequence or the MAGIC based radiomic signatures could potentially predict pathological complete response in TNBC during neoadjuvant systemic therapy. This data also shows the potential application of MAGIC radiomics model for improvement of response assessment in TNBC. This was an example. This was a patient who was included in the trial. So these are the images. These are the initial images at baseline, followed by the images at C4 and at the after completion of 4 cycles, and followed by pre-surgical assessment by MRI. So the pre-surgical radiomic model based on C4 imaging predicted a non-PCR, and as we can see that the pre-surgical imaging showed residual disease, and this was confirmed by pathology at surgery. So this was quite an interesting sequence. So although we know that there are certain features like peritubular edema and central necrosis that are associated with worse recurrence-free survival, but these new MR sequence will definitely help in understanding the tumor heterogeneity in patients with TNBC and more targeted and personalized therapies. Thank you.
Thank you, Dr. Richa. So more and more research and the abstracts that we are presenting today support that MR can really help us in predicting response and predicting it very early on, where we can intervene for patients who are non-responders, as well as maybe de-escalate treatment who are the responders. So thank you. Now we go on to the next speaker, Dr. Parul Agarwal. She's the consultant radiologist at Max Super Speciality Hospital, New Delhi, and she'll be talking about diffusion-weighted MRI for prediction of pathologic complete response in HER2 breast cancer treated with pembrolizumab plus neoadjuvant chemotherapy. Dr. Parul?
Yeah, hello.
Hi.
Yeah, I'm just sharing my screen. Yeah, that's it. So is this visible? My presentation is visible right now?
Yes, it's visible.
Yes, ma'am.
Yeah, okay. So shall I start?
Yes, please.
Yeah. So here I'm presenting an abstract which was presented at St. Antonio Breast Cancer Society on December, which was conducted on December 7 to 10, 2021. So this is an abstract regarding the diffusion-weighted MRI for prediction of pathological complete response in HER2 breast cancers with pembrolizumab plus neoadjuvant chemotherapy. Next, please. So this was the entire extract. Next, please. So pembrolizumab was the first immunotherapeutic drug which was evaluated by I-SPY2 trial. Pembrolizumab plus paclitaxel achieved nearly threefold pathological complete response rate over paclitaxel alone. Diffusion-weighted MRI demonstrated its ability to predict pathological complete response after 12 weeks of neoadjuvant chemotherapy in ECRIN 6698, which was a sub-study of I-SPY2 trial. This study presents the analysis of diffusion-weighted imaging for prediction of pathological complete response for the breast cancers treated with or without pembrolizumab. So these are the quoted images, how the cancers appear on diffusion-weighted ADC or DCE with or dynamic contrast enhanced MRI studies. Next slide, please. So this was the study schema that an initial pretreatment MRI was obtained with diffusion, and T1 was obtained after 3 weeks of combined therapy or alone paclitaxel. So there was a patient cohort of 249 HER2 positive breast cancers The experimental arm, there were 69 patients enrolled, and a combination of pembrolizumab plus paclitaxel was given to these patients, and there was a control arm of 180 patients who received only paclitaxel. The outcome measure was a pathological complete response on surgery. Next slide, please. So on the MRI, DCE MRI and DWI were required at a pre-treatment, and which was labeled as T0. And after 3 weeks of treatment, that was labeled as T1, of either paclitaxel alone in the control group or pacli plus pambro combination in the experimental arm. So DCE MRI, the functional tumor volume was calculated, which was a measure of vascularity. And on the diffusion weighted ADC images, which measured the water diffusion within the tumor. Mean ADC was used to quantify the tumor aggressiveness. Lower the ADC means more aggressive is the tumor. Next slide, please. Next, yeah, sure. So to assess the treatment response, a pre-treatment and a post-treatment, like after not completed treatment, after 3 weeks of the treatment, these 2 MRIs were obtained. So this is one patient whose ADC was, whose ADC was 1.05 into 10 raised to the power minus 3 millimeters cube plus per second at the pre-treatment level, and after 3 weeks, the ADC values raised to 1.13 into 10 raised to the power minus 3, showing that there was a response. Next slide, please. So the results were analyzed as area under the ROC curve of ADC or FTV at T1. And these were these showed that ADC achieved higher area under curve than the FTV in the pambro arm, and ADC and FTV resulted in similar AUCs in the control group who were treated only with paclitaxel. Next, please. So this shows that in the experimental arm, like the patients who received pambro plus paclitaxel both, significant difference was observed in the ADC change for a pathological complete response versus a non-pathological complete response. Whereas in the control group, the difference in the ADC change for pathological complete response versus non-PCR was not statistically significant. Next slide, please. So with this presentation, they showed that FTV is a standard imaging marker. Generally it is said that the functional tumor volume is a standard imaging marker in I-SPY 2 trial and has been used to adaptively randomize treatment. But this abstract showed that diffusion weighted imaging ROI delineation strategy may help ADC to predict pathological complete response prior to FTV in cases HER2 breast cancers treated with immunotherapy. The study, however, has the following limitations. Sample size was prohibited because of the small sample size. The sample size prohibited the subtype specific analysis, and the pambro arm treatment was a mix of pembrolizumab and paclitaxel. It was not pembrolizumab alone. Next slide, please. So this study concluded that diffusion weighted MRI may add value to DCE MRI in assessment of tumor response to immunotherapy at early treatment time point. So this study will later on be expanded to other immunotherapy arms in SPY2 as well. Next slide. So this is advocated in this abstract very well, that previous studies have shown that apparent diffusion coefficient adds to the value of functional tumor volume in prediction of PCR. In this study, ADC was tested for early prediction of PCR in the first immunotherapeutic drug evaluated in I-SPY 2 and found that change in the ADC during the pembrolizumab plus paclitaxel treatment was more predictive of pathological complete response than the change in FTV alone. Next slide, please. So this was all. Thank you.
Thank you, Dr. Parul. Now it brings us to the last poster of this session, and it would be presented by Dr. Sangeeta Taneja, consultant radiologist at Indraprasth Apollo Hospital, Delhi, and she'll be talking on associations of baseline breast MRI metrics and immune filtration with chemotherapy response in triple negative breast cancer. Over to you, Dr. Sangeeta. Hi, Dr. Sangeeta. Can you please share your slides?
Are you able to hear me? And are you able to see the screen as well?
No, we can hear you, but we can't see your screen yet.
Okay, just give me a moment. So are you able to see the screen now?
We can see the screen, but it's not full screen.
Just a moment. Give me a moment. Yeah, so you can see the screen, right? Okay, at the outset, thank you, Dr. Jyoti, and the entire organizing team for making me a part of this wonderful academic platform. And I must say, we've learned so much till now with all these talks that there is so much potential to imaging as far as management of breast cancer is concerned. It's not only diagnosis, but we can actually play an important role in the management of breast cancer. So today I will be presenting this abstract, which had been presented in the San Antonio Breast Cancer Symposium. And it was a study which was conducted at Seattle Cancer Center by Dr. Kaizeroni et al. And the study was titled as the associations of baseline breast MRI matrix and immune infiltration with chemotherapy response in triple negative breast cancer. So in this study, they have tried to evaluate not only the MRI matrix, the MRI radiomic parameters that can help us assess the response to neoadjuvant chemotherapy, but also they have included the degree of tumor infiltrated lymphocytes obtained during the biopsy specimen prior to the treatment, which has already been found to be a prognostic indicator. Also, an important part of this study is that this study reads only the baseline MRI characteristics. They have tried to evaluate the first pre-treatment MRI that was done to identify the radiomic features of the pre-treatment MRI and escalate it to predict the therapy the response to chemotherapy. So the background of the study goes as improving the prediction of neoadjuvant chemotherapy response in early TNBC would provide the opportunity to consider adjustments to regimen prior to initiating the therapy. The degree of tumor infiltrating lymphocytes prior to treatment is prognostic, and the dynamic contrast enhanced MRI of the breast matrix enable a non-invasive assessment of the tumor microenvironment. The aim of the study was to investigate the value of pre-treatment MRI matrix in addition to the tumor infiltrating lymphocytes for the prediction of NAC response in TNBC patients. The patients were between stage 1 to 3 of triple negative breast cancers who had undergone a pre-treatment breast MRI and received chemotherapy, approximately with a total patient number of 115. The MRI parameters which were included were from the non-contrast MRI diffusion weighted images, that is the mean ADC, and from the dynamic contrast enhanced MRI, they used the tumor longest diameter, the peak percentage enhancement, the peak signal enhancement ratio, and the functional tumor volume. I'll just elaborate on all these parameters.
The tumor longest diameter, as its name suggests, it is the longest dimension on the first post-contrast image. The peak percentage enhancement is the percentage increase in the first minute contrast study. The peak signal enhancement ratio was the signal enhancement in the early and the delayed phases, a ratio of that. And the functional tumor volume, which has been derived, there have been several studies on that, in which they have fixed a threshold of the signal enhancement ratio. And all those boxes which are showing an enhancement above that signal enhancement ratio threshold were considered for the functional tumor volume. The immune filtration, or the TILs, were identified from the diagnostic biopsies, and it was available only in 60 patients. And the response, a pathological complete response at surgery, was taken as the endpoint. So, and what they found was that the pre-treatment TILs, as you can see here, they were significantly higher in the PCR patients. So all those patients in whose biopsy specimens the tumor infiltrating lymphocytes were higher, they achieved a PCR. Pre-treatment TLD, as you can see here, was significantly lower in the PCR patients, as in the whole cohort, as well as T1 and T2, whereas in the higher stages, it was the TLD was not significantly predictive of the response. A pre-treatment functional tumor volume was also found to be significantly lower in the PCR patients. As you can see here in the PCR for the whole cohort, the patients showing PCR had a significantly lower functional tumor volume, as well as in the T1 and T2 group, but it was not the same with the higher stages. Similarly, the pre-treatment peak percentage of enhancement was significantly lower in the PCR patients again. And when they combined the data from the DCMRI and the tumor infiltrating lymphocytes, they found that the AUC curve for the whole cohort, as you can see, in whom the TILs were available, there was an improved AUC from 0.62 to 0.67 if they included the peak enhancement, and if they included the longest diameters, the AUC improved to 0.76, which means that if we combine the TILs and the MR imaging parameters, there is an improved area under the curve. These are just few examples which they have shown in the abstract about the peak enhancement maps. As we can see here, this is a T1 and T2 stage tumor in which with the complete pathological response in surgery. And if you see this pre-treatment MRI, the parametric map shows lesser enhancement. There are more blue areas and green areas as compared to the non-PCR, in which the peak percentage enhancement parametric map shows a higher PE. This is an example for the T3 and T4. Well, the PE was, as you can see, is not very predictive. This is a necrotic tumor, and this is a large tumor with a lot of red areas, large and peak enhancement. So what they have concluded from their study was that these baseline dynamic metric parameters like the tumor size, the functional tumor volume, and peak enhancements, and if immune filtration added to them, were strongly predictive of neoadjuvant chemotherapy response in triple-negative breast cancers stages T1 and T2. There were no imaging metrics which reached significance in T3 and T4 patients. Even the signal enhancement ratios and ADC did not reach significance in either of the tumors in their study. In future work, they intend to evaluate these changes in imaging and pathology metrics over the course of neoadjuvant chemotherapy to predict response. So this is how the response with chemotherapy would appear on a parametric map for the peak enhancement percentages. This is the baseline, mid-treatment, and the pre-surgical. As we can see, the enhancement has, there is not a complete response, but the enhancement has definitely gone down drastically. Thank you.
Thank you, Dr. Sangeeta. I personally feel at the end of the day, it will be the integrated approach where we use imaging, pathology, as well as the clinical profile of the patient to help identify patients where we can really go and de-escalate treatment.
Absolutely. Absolutely.
I would also like to thank all my speakers. This was the last abstract in the session before we go on to the panel discussion. And so I would like to thank the speakers who have really critically reviewed all the abstracts and help us understand the emerging strategies in the treatment of breast cancer. So hopefully we'll go back with lessons learned that will steer our future practices in the best interest of our patient. So with this, we go on to the panel discussion. We will try and understand the various levels where de-escalation can be done and who are the right candidates to whom de-escalation can be offered. Sharing my screen. Aram, can you see my slides?
Yes, ma'am. Yes, ma'am. Perfect.
Okay. So at the outset, let me, so the topic of today's panel discussion is de-escalation in breast cancer and the role of imaging. And at the outset, I would like to introduce my panelist, Dr. Meenu Walia, who is the Senior Medical Oncologist at Max Institute, Delhi, Dr. Kanchan Kaur, who is the Director of Breast Services in Medanta Hospital. Then we have Dr. Smriti Hari, the professor in AIMS Hospital Radiology Department, and Dr. Sangeeta Taneja, who is the senior radiologist in Apollo Hospital, New Delhi. So coming to de-escalation, so we have seen there are a number of trials going on, and we have analyzed few of them today. And it's really finding the optimum balance of sufficient amount of treatment. So oncological output are at their maximal efficacy, but not over-treating and going on to the other side of the curve into the realm of unnecessary or unneeded toxicities. So trying to understand the de-escalation. So we all are very well aware with de-escalation in the breast. So it started with radical mastectomy in the olden days. From there, it came to modified radical mastectomy, and then to total mastectomies and lumpectomies. So for the smaller tumors, we were doing lumpectomies, but for larger, we were doing total mastectomies. And with this, the role of imaging became more and more important. As the patients were going for lumpectomies, it was very important that, a good work was done for tumor mapping using mammography, ultrasound, as well as MRI. And then we learned the skills of wire localizations and even bracketing wires so that we could help our surgical colleagues in removing those small cancers using lumpectomies. And as we went ahead, it came to a stage where even the larger tumors were given post-NACT. They went for lumpectomies, and then we started on and acquiring new skills. We were clipping the nodes and then putting the wires, and lumpectomies were being performed. So we have seen a lot of trials around de-escalation in breast cancers. So basically what we are trying to do is de-escalate or reduce the oncological treatment if we can do that safely. And for that, it's very important to identify the right subset of patient as well as de-escalate in the realm of surgical procedures. So once we come to de-escalation of chemotherapy, can I ask Dr. Meenu Walia, ma'am, can you tell us which are the areas where you safely feel that you can de-escalate the standard medical oncological treatments in patients of breast cancer?
Dr. Jyoti, we have enough data from I-SPY2 if we see that we can predict responses to neoadjuvant chemotherapy on the basis of radiological data also. And there are places where you can de-escalate therapy or even escalate therapy depending on the responses. For example, in today's world, in breast cancer, for most of the HER2 positive breast cancers and most of the triple negative breast cancers, we are now moving towards neoadjuvant chemotherapy, neoadjuvant therapy. And after neoadjuvant chemotherapy, we complete the courses of neoadjuvant therapy and then subject these patients to surgery and look for pathological complete response. For example, in HER2 positive, if there is a pathological complete response, then my decision whether I continue with the same targeted therapy or a double targeted therapy or change the targeted therapy, that is to change over to TDM1 or upgrade the therapy, will depend on pathological complete response. So at present, we are depending on our histological parameters to tell us whether the patient is doing very well, and this is the subgroup of patient who will have a good prognosis. We can either de-escalate the therapy, or even if the patients have not received a pathological complete response, whether we need to upgrade the therapy. That may depend on these kind of parameters. And I feel in the future, there will be a lot of aid as per what we gathered from this SABCS, lot of aid, lot of potential to imaging, aid by our imaging techniques also that can probably predict. Like there was a school of thought from I-SPY2 only. If a HER2 positive patient is receiving a neoadjuvant therapy with targeted and taxane, and the patient shows a very good response, do I still subject the patient to anthracyclines, or I can omit anthracyclines? The same goes for triple negative breast cancer. A patient showing a very good response, do I add platinum in a triple negative breast cancer in the neoadjuvant setting, or I omit platinum? Because it is known that the minute I add platinum, the toxicity, the side effects of therapy is going to be much higher. So these are the things which we are looking forward, and probably we want to get answers from our radiological colleagues, from our pathological colleagues, which help us in deciding that how can we de-escalate or escalate therapy.
Right. Thank you, Dr. Meenu. That was really quite informative. So can I ask Dr. Sangeeta, what do you think would be the role of imaging in predicting response to treatment? As Dr. Meenu said, if we can predict response early on the treatment, it will really help them to de-escalate or escalate or make informed decisions regarding the further treatment for breast cancer. So, Dr. Sangeeta?
So as we have already seen, we have listened to our speakers. There are a lot of trials that are going on which are evaluating this role. And there are multiple parameters in MRI, both pre-contrast and post-contrast parameters, which can, which individually or collectively can help and predict the response to neoadjuvant chemotherapy as soon as after the first cycle of chemotherapy. And as the last abstract that I presented, in that even the baseline parameters of MRI can, to a certain level tell us which patients are going to go ahead with a pathological complete response and which patients are unlikely to show a pathological complete response. So I just prepared this list to just emphasize that MRI has been blessed with so many parameters in its kitty that can be used to assess the response to chemotherapy as a baseline and on follow-ups as well, as early as after the first cycle of chemotherapy, mid cycles, and of course our complete response after the completion of the NACT.
Right.
So,
yeah, go ahead.
No, these are just the parameters which have been discussed extensively. For example, we can say that the ECRIN 6698, which is a offshoot of I-SPY2 trial, in that the tumor ADC demonstrates the potential as a biomarker for assessing the early response to immunotherapy as well in the neoadjuvant setting for high-risk HER2 positive breast cancers. And even the I-SPY2 trial, which is being talked about, in that also the functional tumor volume calculations, the reduction in the functional tumor volume can predict the differentiate the responders and the non-responders as early as 6 weeks of chemotherapy.
Right.
With a good specificity, yeah.
Yeah. But I think in our clinical scenario in the Indian population, where getting even a single MR is so difficult, because most of the patients don't have insurance and they have to pay from their pocket. So having those follow-up MRs that we were listening to in the abstracts that were presented, I really feel it might be difficult in our scenario, but the kind of work that, the poster that you had presented, where it was like, okay, one baseline MR, yes, it's still a feasibility, and if we can derive information from that one baseline MR, those kind of the research works that we should really look at, and we need to validate our work in our own Indian population, because that is something I still feel would be feasible.
That is
doing. That is something doable. Yeah, having repeated numbers of yes in setups like AIMS and where patients are not paying from their own pockets, it might still be in the government setups. It can still be taken up there as research work, but in the private setup like yours and mine, it might become a little constrained there.
Absolutely.
Right. And what do you think about the other modalities like PET and contrast enhanced mammo or ultrasound? Could they predict? Because, like, suppose ultrasound, it is very easily manageable. It's available everywhere, and somehow even PET. I don't know why patients still would find it difficult to get a MR done, but most of the people, they are, the first thing that they say, PET nahi kara rahe kya aap hamara? So PET, I don't know, has a more acceptance among the patient. So how about those? Can they help us?
Yes, of course. PET definitely adds to the imaging radiomics, because there is a different category of PET parameters that can be derived. It is not just the bright thing that we see on the qualitative assessment of the PET image. There are a lot of quantitative parameters which can also be derived from the PET. And if we are able to do that, it has been shown in the studies that adding PET to all these MR radiomic parameters can definitely enhance the capability of predicting this response to therapy. So all those cancers which are showing a lesser FDG uptake are likely to go ahead with a better response than compared to those who are showing a much higher FDG uptake or a much higher tumor volume.
Yeah, but somehow I feel ultrasound does not have that sensitivity as the MR or PET that could really help us, early on in the treatment as the sensitivity and specificity the MR has.
Yes, of course. But what I feel, Dr. Jyoti, in my practice is it may not be the primary ultrasound that was done, But if it is a second look ultrasound dedicatedly done to look for either it is an additional tumor in the breast or an additional lymph node that has been identified on MR, I think ultrasound adds a lot, and it can definitely, I think in 80 to 90% of the cases, it can identify that lymph node which was shown on MRI or PET to be avid.
Can I add a bit here?
Yeah.
Ultrasound, if it is done along with shear wave elastography, it has good potential in seeing response, as we have demonstrated in one of our studies. And with the AI, like the way Vinita showed that abstract, I think there is good hope that ultrasound in future may be a good modality for a response assessment after NSET.
Yeah, and we need such things because ultrasound is one modality which is very readily available.
Yes,
So
and shear wave elastography will make it quantitative as well. It will not be completely operator dependent. You will have values to say that it is, the stiffness is decreasing, and that will be a surrogate for response.
So we can objectively then measure these parameters. Okay. So this was the abstract, the poster that was presented last time in 2020. And this very clearly shows that if we are able to predict response, then as even Dr. Meenu had just now specified this. So after 12 weeks of taxanes, if the MR which is done at baseline at 2 weeks and at 12 weeks, and if it is very confidently telling us that there is a complete pathological response, so in this in one of the arms of I-SPY 2, they're also doing biopsies and confirming that yes, there is a complete pathological response. And when we are 100% sure that there is this response, or there is this good response, then they are very confident about skipping or omitting 4-week bi-weekly cycles of anthracyclines and going directly to surgeries. So this is one area where if we can very confidently predict early on in the treatment that yes, there is going to be complete pathological response, or there is a complete pathological response, then we can de-escalate the oncological treatments and save the good responders from the toxicities. This was another study where they had taken the integrated model for early prediction of neoadjuvant negative breast cancers. Again, they said that total volume reduction and if it is stage. So this is what I was talking about just before starting the panel discussion. So it's more likely to be an integrated approach. So here they are taking into imaging, they are taking clinical stage, that is they are node negative. And if TILs are less than, more than 20%, then these are the patients who are likely to have a much better response if we are taking all three into account rather than just one parameter into account, and then we can predict complete response. So now coming to the surgical management, we have seen how things have de-escalated, or the management has de-escalated in the breast. Now going a step further, we had today seen the small trial. It's an ongoing trial, so we'll be very seeing the results in another couple of years, whether we can omit surgery in early breast cancer. And in the another scenario, that is if there's a complete response post NST. These were the trials which were presented by Dr. Rupa and Dr. Smriti, whether again we can omit surgery and do the excision using a WAB. So let's hear from Dr. Kanchan. What is your take? Do you think there is any promise, or do you think this is just a hype and there is no hope in these kind of trials? Dr. Kanchan?
Yeah, good afternoon. Thank you for having me on, and what a wonderful learning session this has been. So radiologists are in a very exciting space right now, unlike us surgeons, because we are seeing our work being cut more and more. But it is an era of benefiting the patient where we are going from a maximum tolerable treatment to the minimum effective. And I think we all have to look at these trials and look at these thought processes with a very open mind. But at the same time, we have to take them with a pinch of salt unless we have enough validated data to prove that these are going to be successful in the clinical scenario, and also identifying the right kind of patient in whom these can be, later on applied. Now, coming on to, trials which are looking at either completely radiologically, under radiological guidance, without a surgical cut, removing the tumor, versus checking to see whether we should go back to do surgery in an exceptional clinical responder in the post NAC setting. So I'll talk first about a little bit about the small trial, because all of us come with certain biases in mind when on how we have been taught to approach oncological treatments. And as surgeons, one thing which is deeply rooted in our psyche is that if I am surgically removing a tumor, the margin status plays a huge role in determining what kind of adjuvant treatments or whether further surgery is needed. And when we are looking at trials which are looking at just radiologically pulling out the tumor, margin status, is it going to be that effectively determined or not, is something that remains to be seen. And in patients in whom you are downgrading or de-escalating to not doing breast surgery and just radiological extraction of the tumor, are you then going to do something for the axilla, which is also that minimized and that de-escalated? So I think that needs to be looked at, and definitely not something that we can wave off as something that cannot be implemented in future practice. I think as screening becomes more and more advanced and we find more and more small tumors, definitely patients will benefit from minimal surgical intervention. Coming on to the post-NACT, I think that's a huge discussion, and Dr. Smriti also just spoke about it. See, we have to balance, because the data up until now for VAB, for bed biopsies in post-NAC patients has not given us the confidence, because the FNRs are very high. But the AI model that has been applied to VAB has suddenly shown huge promise as being able to predict, and again, we have to take that with a pinch of salt, because that was a smaller study. Now, we have to also look at this from the patient's angle. Yes, we are very excited as radiologists and as surgeons that we're doing less. But think of it from the patient angle. You've done bed biopsy and shown that there is no residual tumor, so the patient hasn't gone on to surgery. But are you increasing the amount of imaging that the patient is going to have over the next couple of years to ensure that she doesn't have a recurrence? Will that imaging be more frequent and more invasive than if she had had surgery? And also, are you increasing the anxiety of the patient, knowing that, oh, I did not have surgery, but only a few biopsies were taken? So I think all of these things require a multidisciplinary approach. I think right now, standard of care is not to do bed biopsies, and if it shows that there is node negative, we don't go, if there is response, we don't go ahead and do surgery. Because also, I'm sure Dr. Meenu will agree with me on this, that PCR and residual cancer burden has a huge role to play in determining what kind of adjuvant medical management they're going to offer. And we do know from the CREATE-X and the TDM1 trials that in patients who had residual disease, adding other treatment modalities in the adjuvant setting like TDM1 or in the CREATE-X capecitabine did lead to better outcomes for the patient. So I think we have to look at all these angles. It's quite multifactorial. One study does not help us determine how our practice is going to be, but definitely gives us enough food for thought to see, are there patients in our practice to whom we can extrapolate these, and then look at our own data to understand whether we are now ready to take the next step to de-escalate.
Right. Thank you, Kanchan. Very well said. A couple of things that I wanted to add here, that for early breast cancer, the radiologists are always blamed for overdiagnosis, and then obviously it leads to overtreatment. So this might be, filling up that gap where we are picking up small cancers. We cannot sort of leave them thinking that, it's a favorable cancer, so it's unlikely to go ahead and cause any damage to the patient. But yes, if we are doing VAB and removing them, then that over treatment and over diagnosis, we can bridge that a little bit. And also for the margins, now I've read a couple of studies that said that what they are doing is they're removing the cancer, they're putting that in a one sample bottle, and then they are doing the margins again. So, and that goes into the other another bottle, and then the pathologist tell them that the bottle which had just the margins, is there any residual disease in that, so that you can take things forward from that level. And for the complete response, that MD Anderson trial that was presented by Rupa, where it has added AI, as you rightly said, is really adding a new dimension. We really don't know why few patients respond and the other don't. But when we are putting AI, it is really, giving us that insight that these are the ones which are likely to benefit from de-escalation. So, Smriti, do you have anything to add to this? You do a lot of VABs.
Yeah, Jyoti, I think I also had a lot of hope for VAB being the modality where we could, do it after NSCT and de-escalate surgery. But I think the key is proper selection of patients, because the response to NSCT is variable in various subtypes. And then to make sure that our sampling is extensive and representative, so which can be done if you make it mandatory that a marker clip should be deployed and then retrieved at the time of VAB removal. So the trials up till now have not been very hopeful, except the trial which used AI, and the AI was basically used for patient selection. So proper patients were selected, and we could achieve a FNR of 0% there, which is very, very impressive. So I have hope that with the refinement of our selection criteria, there is a way forward.
Okay, so that's interesting. So this takes us to our next topic. In the surgery, we have seen about de-escalation in the breast, and now we would like to see how we can de-escalate surgical management of axilla. So, so we have come from a phase where ALND was being done for all the patients to now SLNB, and I would like Dr. Kanchan to explain to us the management of axilla in a clinically node negative who is going for an upfront surgery. So what are the criteria? How do you manage those patients, and what are the areas where we can de-escalate?
So in a clinically node negative, the gold standard is a sentinel node biopsy now, and all centers that practice breast surgery as a specialty, if they do find in a clinically palpably node negative patient an abnormal lymph node on ultrasound, they will get an FNAC to prove or disprove that this patient is node negative. So in node negative patients, it's fairly straightforward. We do go ahead and do a sentinel node biopsy. But when we are talking of de-escalation in axillary surgery, we are now reaching a point where we are saying that in the clinically node negative patient, can we de-escalate to the point that a sentinel node also not be done? So that is something interesting to watch out for.
Right. So can you just let us know about the various trials that have helped us to reach to this conclusion from ALND to SLNB, and then take us forward to the next level where we are thinking not to even do SLNB. So what's the various trials that have come?
Yeah, so the timeline for how de-escalation in axilla has happened is quite interesting because, data by default were gathered from studies in which they may not have had potentially at that time, thought of the kind of results that they would produce. And it goes back to the NSABP B04 study in 1970, where I don't think such kind of a trial would be allowed in this day and age. But they were able to randomize patients into undergoing what was a radical mastectomy and the standard of care at that time. And then they divided patients into those who had the radical, patients who had a total mastectomy with treatment of the axilla by radiotherapy and not by axillary clearance. And then they had a group of patients in whom patients underwent only breast surgery with no treatment of the axilla. So neither axillary lymph node dissection nor axillary radiotherapy was done. And the impressive results from this, or what we gathered from this, was that in those patients who had the axillary nodal dissection in that arm, the node positivity rate was around 40%. So we would obviously then presume that patients who did not have axillary surgery also had an axillary burden, which was there in 40% patients. So you would then extrapolate to see that if you leave behind those nodes in those 40% patients, it should affect their recurrence-free survival, it should affect their overall survival. But surprisingly, only 17.8% of patients in that arm that did not have any axillary treatment had an axillary recurrence, whereas the remaining did not. And there was no significant overall survival or recurrence-free survival change. So this then led on to the very famous studies, the Milan, the Almanac, and the NSABP B32, which then spoke about or brought about the change in how we approached the axilla, and the concept of sentinel lymph node biopsy came around. So those who were clinically node negative, so node positives were still going straight away to axillary clearance, but those who were clinically node negative were having a sentinel lymph node biopsy. And the standard of care in these surgeries was that if the node is positive, the patient shall proceed to an axillary dissection, whereas if the node is negative, then you can spare the axilla. So that was the first big step that we proved through studies to say that yes, we can spare the axilla. And there were so many, I think for want of time, I'll quickly go through. Then the next thought process was that even in the node positive patient, do we really need to do an axillary clearance? Because 60% of patients who underwent axillary clearances did not have non-sentinel node involvement. And please understand here that we are talking of Western data where tumors are in early stages. We are not talking of Indian data. It would be a dream for us to have 60% patient not have the non-sentinel node involved. So for students who are listening in, we can't just extrapolate this, but yes, that's got them thinking that can they spare the axilla in these patients. And the Z11 was the first trial that looked at it, was beaten black and blue because there were too many lacunae in the trial. But then other trials that came around, Synodar 1 and those that looked at validating Z11 have been able to validate, and now it is standard of care in the West, and hopefully us Indian surgeons will also take that step very soon, that in the patients who have less than one or two lymph nodes involved and have a favorable histopathology, are we okay to de-escalate and not do an axillary dissection? So those trials, none of them, all the trials that Dr. Jyoti just showed on the previous screen, did not show increase in axillary recurrences, did not show significant, change in overall survival or disease-free, distant recurrence-free survival. So now we know that in patients who are clinically N0, and they've had upfront breast cancer surgery, 1 to 2 node positive patients, you can de-escalate and you do not need to proceed to do an axillary clearance. But what is the role of axillary ultrasound?
So you have been talking about clinically node negative, and you decide then when to do sentinel lymph node and when to do ALND, and it's all on clinical
Can I mention something here? Jyotiland, when we are talking of de-escalation in the breast, I know my radiologist will tell me there are 3 tumors, 4 tumors, this tumor measures this size, it is this much distance from the other tumor. But in the axilla, you're not going to tell me I can see 20 nodes, one looks abnormal, the rest look normal. So I think that is where the role of axillary ultrasound needs to be refined if we have to have the confidence of axillary de-escalation. So I'll let you go ahead and ask the radiologists.
Okay, so Dr. Smriti, what's your take on axillary ultrasound? How sensitive they are? What's their specificity? And also, Dr. Sangeeta, what do you think is the role of MR and PET in evaluating axillary lymph nodes?
Yeah, so Kanjan, I completely agree with you that the confidence that the radiologist can generate on ultrasound when there are multiple nodes involved, and plus with the higher rate of reactive lymphadenopathy in our Indian population, that leaves much to be desired. So I have done a feasibility study in my institution for clipping nodes and trying to see if we can remove all the disease in the responders
Smriti,
after CT.
yeah, sorry to interrupt, Smriti.
Yeah.
We were just talking right now on the upfront surgery, not NST patients. So if you could just tell in the routine, breast cancer, if what's your this thing on axillary ultrasound, how sensitive it is, and
right. The sensitivity is quite good, but the problem is specificity, because often it is not possible to differentiate reactive lymph nodes from metastatic, because they could have diffuse thickening as well, and that is the commonest finding in metastatic lymph nodes. So over there we tend to be overdoing our axillary biopsies, and that's the reason we have to prove by biopsy that a particular lymph node is metastatic or reactive. But I do find the Stavros teaching very helpful, that you must look at the contralateral axilla as well, because if the lymph nodes are all looking similar on both sides, it's likely reactive lymphadenopathy. So yes, ultrasound is as yet not specific enough. So it has to be followed up with an axillary FNAC or a biopsy in suspicious nodes. Yes.
If it is a smooth cortical thickening, what's your cutoff when you start putting needles in it? Is it like if a cortical thickness of 3 millimeters or more that you put a needle in, or?
I have had a big learning curve here. Initially, I was putting in needle right at 3 millimeters and more, and I ended up with lot of negative biopsies. So that means I was biopsying too many non-metastatic nodes. So slowly I have refined the criteria, and now I only put needle in diffuse cortical thickening if it is a unique node. If the other nodes around are looking more normal, it should not be that all the nodes are looking same, because it's unlikely that in an early stage cancer you'll have metastasis to so many nodes. So looking at the primary tumor also is important. If you are getting a primary tumor which is about 2 centimeters and then multiple nodes with diffuse cortical thickening, it's more likely that it is reactive. So I would not put my needle there. So more than the 3 millimeter thickening, it is how the adjacent nodes are, what is the overall picture. I always do a contralateral axillary ultrasound also to try and make up my mind whether I want to put in a needle or not.
Dr. Sangeeta, what's your take on axillary lymph nodes on PET and on MR?
So now, since we are talking about the primary at the time of primary diagnosis, I think when we are doing a PET MRI here at Apollo, or even if you're doing a PET CT and an MRI, they have an additive advantage in improving the specificity of the identified node. Besides, being sensitive enough to diagnose more nodes that can be done on an ultrasound. So there are similar criteria on MRI which I usually follow, and even the smaller nodes less than a centimeter with high resolution MR images, I think we are able to a certain level discern that this node seems to be involved and this doesn't. Though I have not been able to, accumulate the data and analyze it for my own benefit, for our benefit, but I think that MRI, and then if the PET uptake is also shown at that enlarged on that small node, it adds to the specificity.
So basically, if on all three modalities, like it's a single abnormal node on ultrasound, which is showing uptake and it's looking abnormal even on the MR, then the specificity goes high. But just on single modality, and especially if you don't have those typical features where you have loss of hilum or you have an eccentric cortical nodule, then just relying on the smooth thickening, then the specificity obviously goes down with axillary ultrasound.
Yeah. Of course, granulomatous nodes in our clinical practice, they are the add to the dilemma. But as Smriti rightly said, then you are usually likely
have
to find
multiple
a bilateral node or a high node up in the neck or anywhere else in the body. Then that adds to the
the decision making
for us to take decision. Yes.
Going on to patients who are undergoing neoadjuvant chemotherapy or systemic therapy, but they're clinically node negative. Dr. Kanchan, how do you decide when are you going to do a sentinel node biopsy? Is it before starting the chemotherapy or is it after systemic therapy?
There has been an evolution in the thought process of the timing of sentinel nodes in patients undergoing NACT. Initially, we would do a sentinel node biopsy prior to NACT because the thought process was that NACT may alter or disrupt the normal anatomy of the lymphatic channels, and you may miss the normal sentinel node because then the node that you find as sentinel may not be the true sentinel if there has been complete response. But then studies over the years have shown that you can safely perform sentinel node biopsy in a CN0 patient after completion of neoadjuvant chemotherapy, and even in our practice that is what we have done. We have moved from doing pre-chemo sentinel node to doing a post-chemo sentinel node, and there is no difference in the efficacy.
Right. This was a meta-analysis of SLNB after NAC. So as you said, there was a lot of dilemma, but there have been few good meta-analysis that helped the surgeons take the decisions that they have taken of doing SLNB. It's technically feasible and accurate for axillary staging in the initially clinically node-negative breast cancers after NAC. But what about de-escalation in clinically node-negative patient who become, in clinically node-positive patient who become node-negative after NST?
If you look at standard of care now, that if a patient who was clinically node positive prior to chemo becomes clinically node negative after chemo, can you de-escalate in the axilla and not do clearance? There were multiple studies that were done, but in those cases, what we have to understand that it cannot be the routine sentinel node biopsy procedure alone, because the FNRs in these patients were high, and we then realized that doing what is called a specialized or a personalized sentinel node biopsy, in which you have added other things, like you're definitely using dual markers for identification, you're using IHC, and very importantly, you are identifying 3 or more sentinel nodes. So this is what is called the plus sentinel node or the added sentinel node, whatever you may call. So rather than just doing the routine sentinel node, if you are able to do targeted axillary dissection, identify 3 or more nodes, you do IHC, then the FNR rates fall significantly below the 10% mark, which 10% we think is the magical number. And yes, in these patients, you may skip clearing the axilla. But standard of care right now is that even if there is micrometastatic disease in a node post NACT, then clearance is done.
Right. That is what we are doing in Indian population. But like in the West, people are now more and more, doing, as you said, the plus SLNB and trying and avoiding ALND. So what's the role of clipped node? So it helps then to reduce the FNR of these sentinel node biopsies.
So see, the premise is that if a lymph node was looking abnormal on ultrasound prior to chemo, this was the lymph node in which you did the FNAC and proved that it was a metastatic node. After response, when you do a sentinel node biopsy, is this node going to be the same node that you had FNA'd? In fact, in studies that looked at targeted axillary dissection, in about 20% cases, the sentinel node was not the clipped node. So clipping of the node, yes, would help to ensure that the lymph node that was FNAC proven to be metastatic is retrieved during surgery and analyzed on the same thought process that we have for a clipped tumor bed in the breast. So the thought process is the same, that we are ensuring that the initially biopsy or FNAC proven lymph node has been retrieved to study the response. And clipping a node does help the surgeon to definitely reach that level of confidence. And clipped nodes, in fact, even we tried in our setting, but cost becoming a big issue. But for the 6 or 7 patients that we did, at least, we realized that all our sentinel nodes were the clipped nodes, but that was just 6 or 7 patients that we had done. But I believe Dr. Smriti has a larger number of series.
So I was just going on to Dr. Smriti. Dr. Smriti, what's your experience of clipped nodes? So this is the study that Dr. Smriti has shared with me. So I'm putting it up for the benefit of our viewers.
Thank you, Jyoti. We did try clipping nodes and trying to see whether the removal of clipped node will add to the response assessment. And the gold standard was axillary lymph node dissection. As in my institution, we are still doing axillary lymph node dissection for node positive patients, even if they become node negative. We are not really doing post NACT plus SLNB. So the number of eligible patients, though we clipped about 69 patients, but the number of eligible patients who underwent surgery in our institution were 32. And in that, we got a very good FNR of 4.8%. When you add the post-NACT ultrasound findings and the clipped node histology, the clipped node histology alone was 28.6% FNR, which is little high. So that means that is because our patients are little advanced and most of the patients had more than 3 nodes. So you cannot just comment on the clip node histology. There are other nodes also. So in the post-NSET ultrasound, you can see whether those nodes have resolved or not. Out of the 32 patients, 10 patients had less than 2 lymph nodes involved, and in them we had a good result of this study.
Sorry to interrupt, ma'am. You are left with just 2 minutes to conclude your panel discussion. Thank you.
Okay. So I just wanted to ask Dr. Smriti how easy it is to put wires after putting clipped nodes. Obviously, it becomes difficult.
What helped us in achieving a high rate of success in this feasibility trial is the fact that we were seeing these lymph nodes after every cycle. So we had a visual map of the lymph node which was biopsied and clipped. So it was easy to identify the clip because we knew where to look for it. And in fact, we could clip the nodes in all but one patient. Locate the nodes in all but one patients. Mostly with ultrasound, and wherever we were not sure, we put a ultrasound guided wire also. In 2 patients, we put a stereotactic wire for locating that clip node.
Dr. Smriti, can I quickly ask, since you do have good experience with this, when we were and I know this question's been asked many times, it's not always just that one node that you have FNA'd and clipped. Sometimes there might be 3, 4, 5 abnormal appearing nodes, and which node do you decide is going to be clipped? Because you're not going to put clips in every single node. Then does targeted axillary dissection actually become that targeted after completion of chemo because we clipped only one node?
That is absolutely a valid point, and that is why the result of our study was that we should be doing this only when the maximum number of nodes involved is 2. So it should be a oligonodal scenario, not when once more than 2 nodes are involved. I think that patient is anyway a candidate for ALND then. If you want to de-escalate surgery with targeted axillary dissection, we should choose patients who have less than 2 abnormal nodes on the pre-NSET ultrasound, and it would be better if we clip both the nodes.
Excellent, thank you.
Okay, so all those, there are other options also available for wireless localization, which are the radioactive and the magnetic seeds. That's a food for the thought, and maybe in future even we can start doing in our country. And these were the abstracts that were presented in last time SABCS on these 2 this thing. So in summary, when we come to axillary lymph node management, I think Dr. Kanchan has very rightly put that we have come from ALND to SLNB, and now we are coming to a stage where we can even think of omitting SLNB, and in patients with neoadjuvant chemotherapy, if we are clipping the nodes and we have like FNA or biopsy proven lymph nodes, in selected patient group, we can still omit ALND. That would be, right now we may not be doing it, but that is one thing that we would be really looking forward by accumulating our own data, that even in node positive, if we can just stick to SLNB rather than doing ALND. So with this, I would come to my last question. Dr. Kanchan, what are the challenges that you face in Indian population? You have such thorough knowledge, and you would really like to de-escalate as much as possible. But what are the challenges that you face in doing so?
So, when I talk about challenges, I think challenges that the Indian oncologist faces are at multiple levels. So the challenge that a doctor who is practicing in the periphery is facing is very difficult from someone in a government setup which can afford to give the latest treatment, to the private sector, where we would love to give everything, but obviously cost is a factor. So what I want to say here is, before we talk of challenges, what is important for us to understand is that it's very exciting to hear about de-escalation studies, but we have to definitely slow down and understand whether we have reached that level of maturity as breast clinicians. And when I say clinicians, I'm including my radiologist, pathologist, and you know, the entire team. Have we reached that point? And the biggest challenge is that we have not. We still suffer from very poor, I wouldn't say very poor, but we don't have specialized radiology services available. And we do know that if we are going to de-escalate, which is what the topic of discussion at SABCS this time was, then we do need a very good and thorough radiology support, which is a challenge that we face. Also in the Indian population, even in centers like ours, where we have the best of radiology available, is our patient able to afford it? One. Secondly, is our patient intelligent enough to do informed decision making? Because you might tell the patient, I can clip this tumor, it will downgrade, and I can do breast conservation. But a general surgeon sitting in the community will tell them that is risky, just remove the breast, just remove the lymph nodes. So that's a big challenge we face. And I think when we meet at meetings like this and all the experts are together, I think the onus is on us clinicians to also pass this message down to the general practitioners, because they sometimes play a huge role in making the patient decide what kind of treatment they're going to have. Another challenge, I think, in the Indian population, which we all harp about, is that patients come late. And if they are coming at later stages, then obviously the extrapolation of Western data, where they see early breast cancer and a different profile of breast cancer, we cannot just extrapolate until we all have done our own validation studies. But the future is definitely looking bright, and I'm sure we all stand to learn a lot as we go along, and conferences like this, which have been beautifully organized, help at least us to understand these challenges and how best we can look at overcoming them.
Very rightly said, Kanchan. Dr. Meenu, do you have anything to add to the challenges that you as clinicians who were actually, facing the patients, any more challenges that you feel that you face with the Indian population? And also at the end, if you could give the closing remarks before we close the session for today. Dr. Meenu.
Dr. Jyoti, I think Dr. Kanchan has brought out very, very valid points. Yes, a lot is changing, a lot is happening, and we are all talking of de-escalation, but we have to also understand our community, our scenario, what are the other kind of things that we are really facing. She brought out a very important perspective about the availability. Yes, we are talking about MRIs, imaging, responses to treatment, but yes, the availability of trained radiologists, the availability of good mammography machines also at all the center, whether it is available or not. And I will rather take it a step further. In spite of saying, so many of us always harping about the newer treatments, the newer techniques, and for example, like in today's world, when we talk about the neoadjuvant chemotherapy in triple negative breast cancers and HER2 positive breast cancers, and so often we still see patients with advanced breast diseases, with POD ornament, with skin involvement. Still, the perspective is there are two different kind of perspective. One is perspective from the patient perspective, who still feel yes, why the treating team has not advised surgery upfront, because the thought process has been ट्यूमर है उसको निकालो और उसको जल्दी से बाहर फेंको. That is the main thought process. So anytime when even my surgeon when refers for neoadjuvant chemotherapy, even then we face that sometimes the patient drops out, patient goes away because the local practitioner, somebody else somewhere has told them that surgery is the way to go. And apart from that, even a step further, I will say is sometimes we find these patients neither going for surgery nor going for neoadjuvant therapy. We do find people who will not even come forward for biopsy, chira nahi lagana. I mean, if you can treat me without tissue diagnosis, okay, fine, but I don't want a biopsy. And then there really is also a subgroup of patients where you have made decisions. We talk of tumor boards, we talk of all these things, and the patient just goes away, and you have, I mean, I don't want to say it, but we have Ramdevs of the world giving entirely a different aspect to medicine altogether, and we have quite a substantial proportion of patients educated class, I mean really educated, and it's not only the villagers who will rather go for alternative method treatments, who will go for non-evidence based treatment just because probably that is the easier way out. So these are, yes, the challenges, but again, as Dr. Kanchan also pointed out, and all my radiologist friend, Dr. Jyoti, Dr. Smriti, Dr. Sangeeta, very beautifully pointed out that India is a country of extremes. So we are here, dhabas have always survived along with the 5 stars. So we have 2 extremes of population, and it is everywhere. And what we have to do is it has to be, oncology is first of its kind, which have actually found that treatment is always multimodality. It is a multidisciplinary management approach. It's a teamwork with radiologists, with pathologists, with our surgical, medical, and radiation oncologists. And yes, the time has come that the gears might be moving, rather than the weekly nations, rather than Dr. Kanchan or Dr. Meenu calling the shots that what the patients need next, which chemos or how much of surgery. The time has come, probably in the near future, it will be the radiologists who might be calling the shots. But yes, whatever it is, things have started changing, things are for the better. And if it requires doing what the patient benefits the most with, that is what should be the need of the hour. And I really thank Dr. Jyoti, who was the backbone of this entire piece, the entire discussions and abstract selection, who did all the hard work and had brought everybody, the esteemed faculty here. And it was an excellent session. I myself as a clinician learned a lot from each one of you. And I think with that, I say thank you to all.
Thank you, ma'am, and thank you for giving me this opportunity. It was a great learning experience for me, and I hope everybody has learned something or the other, and have something to go and change their Monday morning practices, and or maybe at least think of certain aspects where they can do more work and validate the stuff that we have seen today. Thank you, everyone. With this, we would disperse.
Thank you, ma'am. Thank you, everyone.
All my panelists, Dr. Kanchan, Dr. Meenu, Dr. Sangeeta, and Dr. Smriti. Thank you very much.
Thank you for the excellent abstract presentation and brilliant panel discussion. So here we close the session. Can we go offline? Support team, can we go offline?